Briefing on the mental health strategy, briefing on respite services and short breaks, no written briefing because we didn't get one, and then a review of respondents in relation to the Adult Protection Bill. So we're just about to go into open session. So can I just advise committee members that the meeting will be recorded and broadcast throughout Parliament buildings and online. Orlia is joining us online. She's there. We have apologies from Diane. Danny Wilnilla. You have an apologies from her?
Yeah, she hasn't emailed in. No.
Sorry.
Yeah.
I must.
She wasn't pleased.
I thought you said Danny was going to be in it. So apologies from Diane and Nilla. Okay, Chair's business, none. Draft minutes. Can I refer members to the draft minutes of the meeting held on 2nd of October? Are members content with the minutes as drafted? Content, thank you. No matters arising. So move straight into the oral briefing from the department, and this is on the review of deliverability of the mental health strategy. Can I refer members to papers at tab 5, page 15 of our main pack? And can I welcome the following departmental officials? So can I welcome Heather Stevens, Director of Mental Health, Ciara McKillop, Interim Director, Community Care Directorate within the SPPG, Fiona McCausland, Head of Adult Mental Health Unit, Helen Dougan, Social Care Lead for Mental Health within SPPG, and Lorna Conn, who's the Project Manager for Mental Health within SPPG. So you're all very welcome, and I'm going to hand over to yourselves just for a few minutes for a brief introductory remarks, and then we'll go straight to questions.
Okay, thank you, Chair and members very much for this opportunity to brief committee members today. It's a follow-up to the briefing that we provided you back in June when the initial findings of the review were starting to emerge. So, by way of background, the review of the deliverability of the mental health strategy was undertaken in order to reassess its feasibility in light of the significant financial constraints that we have faced since its publication in 2021, and with little expectation of any additional funding in the short to medium term. So this exercise was actually a commitment to the Public Accounts Committee in August last year in response to its specific recommendation, and we undertook to identify the key priorities for implementation based on projected resources, and also to consider potential for phasing of the actions as we move forward. And I think it's fair to say, as Minister has indicated in his letter to the committee, it's a really disappointing and deeply frustrating position for us to be in. But it's necessary to make sure that we focus our efforts and make the best use of the resources that we do have. So members will be aware that at the time of publication of the strategy back in June 2021, it was published alongside a funding plan. And that funding plan said that implementation of the strategy was projected to need an additional £1.2 billion over the 10-year life of the strategy. That strategy was seen by everyone as really transformational and much needed in order to improve already really underfunded mental health services in Northern Ireland. So it had, and really importantly, it still has widespread support for what's required to actually make a difference to the mental health of the population of Northern Ireland. However, as I know you will be aware, no additional funding has been allocated to the department to date for delivery of the strategy. So as a result, we have been using, right from 2021, existing departmental resources to progress a number of the mental health strategy actions. So in effect, we're talking now about prioritisation, but we've had to prioritise right from the very start of the strategy with a focus on those actions that even then were seen as enabling or foundational to other actions on the strategy. The review report states that at the end of 24-25, only £12.3 million have been allocated to 14 actions within the strategy, 10 of which have recurrent funding, with the largest proportion of that going to CAMS, going to a new perinatal mental health service, and going to early intervention and prevention. But that figure of 12.3 million represents only 16% of the amount of funding that had been deemed necessary for the strategy's implementation during this period to date. There are 35 actions in the strategy, and out of those 35, 20 have commenced, 6 of which have had no funding. And the review report notes that there has been progress made across those actions, particularly in relation to those that have had recurrent funding. So early intervention and prevention, CAMS, the new perinatal mental health team, progress on regional crisis service, personality disorder, eating disorder, preparatory work on the mental health service, regional mental health service, preparatory work around the mental health workforce, and an outcomes framework which is now embedded in Encompass. So there has been progress. However, without dedicated resources, the fact remains that 15 actions within the strategy have not been commenced. The review involved engagement with over 100 stakeholders, and there was really broad agreement that the mental health strategy does remain the vehicle for the transformation of health service provision. And the review also revealed broad agreement that we did need to focus down on a smaller number of recommendations, smaller number of actions given the resource constraints. But I think it's really important to highlight that that does not dilute the overall commitment to the strategy in its entirety. It is all really still needed. These are all really important actions that we need to deliver on, but rather we are in the necessary position of having to really just sharpen the focus to maximise the impact within that limited resource that we have available, particularly over the next 3 years. So to do that, the review has identified a number of immediate priority, medium priority, and then some low cost or no cost actions. So in the immediate term, it identifies actions relating to the mental health workforce. And I just want to take this opportunity to say that when we talk about workforce, that includes the role of the community and voluntary sector as a really critical part of the mental health workforce in Northern Ireland. They're key but currently underutilised. So they're part of that workforce priority going forward. And crisis remains a priority, alongside this broad principle of eradicating inequity within mental health services. And of course we've made a start in that area already, particularly in relation to crisis and eating disorder and personality disorder. So those 3 priorities have been identified as the immediate focus for 26-27 due to their enabling impact on the existing system, just as workforce and crisis were identified as such back in 2021, which is why we have been working on them so far, and we will continue to work on this year, even in advance of 26-27. The review then goes on to identify 4 medium priority actions. So 2, one relating to mental health and older people, and one relating to digital mental health are proposed to be prioritised in 27-28. And then for 28-29, 2 further actions, the first on CAMS, and then secondly a focus on those experiencing severe and endure mental illness will be the priorities for that year. And the report, as you will have seen, sets out the detailed rationale behind the prioritisation of those actions. So looking at, for example, at strategic alignment, looking at, for example, invest to save arguments, looking at, for example, the reports from external organisations such as the Centre for Mental Health, which is advising governments as to where they need to put their energies and efforts in relation to mental health. And then finally, we have a series of either low cost or no cost actions which have been recommended, and these include things like enhancing the service user experience through, for example, more training on compassionate care, streamlining governance and commissioning and planning arrangements. That's a major area of focus that we can do and really look hard at ourselves to make sure that our systems and processes are as lean and efficient and non-duplicating as they can be. We can use the outcome measures that we've worked so hard to create and embed to really test where are we getting results and how do we use what we know now to inform further service development. And we need to improve transitions between CAMS and adult services. So work is already underway in relation to a number of those, particularly around streamlining governance. And we're conscious that there are a number of strategies and action plans operating in this space, and they all require commitment from our partners and stakeholders in order to move forward. And so we are determined to look at that and rationalise where possible, to avoid unnecessary duplication and make ourselves as efficient as we can. Just to say a word about the current year, 25-26. So we have just published our delivery plan for 25-26, and I have to say, in the expectation of there being no additional funding for this year, we have set out objectives and a series of actions which basically take forward the areas of work already underway, living within that 5.9 million envelope that we have for this year. But looking ahead, we're determined to use the review of deliverability then to inform our work for the next 3 years. And we're about to start work now with partners in that co-design process to particularly focus on workforce and crisis. And on workforce, what we will do is bring together the work that we've been doing to take forward the EY report from July 23, which looked at the workforce requirements of the statutory sector. We're taking that forward along with another report which has yet to be published. It will be soon, also carried out by EY this year, and that was on the scope and capacity of the community and voluntary sector to be engaged. So we have recommendations and actions from that which we can now bring together so that we have a coherent look at workforce in this current year. And obviously we're going to also focus on continuing on those low cost, no cost actions. So, Chair, delivery of the mental health strategy remains our ultimate goal, and we're not going to withdraw from that. We're not diverting, but it's just in common with all others of health, all other areas of health and social care. We're having to cut our cloth accordingly and really sharpen our focus. I just want to say another thing about aligning our efforts to the reset plan, because it's really important that we do that. The context has changed from the strategy was published back in 2021, and in particular the new plans to have a neighbourhood model of care, which we very much welcome and see it aligns really nicely with the ambitions of the mental health strategy. And we know that there are already a range of mental health services delivered at community level. Our community mental health teams are really the linchpin of the mental health service and make that connection between primary care and acute care. We've got MDTs now funded separately, which are being rolled out, and that will see, the addition of mental health practitioners, hopefully in all GP practices in due course and over time. And we're very, very fortunate in Northern Ireland in that we have a large and engaged community and voluntary sector that is spread all over Northern Ireland. It's not just in pockets. We have tremendous potential there, and they're already doing, as you fully know, huge amounts of really, really good work, and we just need to bring that all together. So we're not starting from a zero base when we're talking about looking at neighbourhood models, but we have the opportunity to work with colleagues who are developing that model to make sure that whatever we do is aligned to that, sits nicely with it, and fulfills its potential. We're also working really hard to ensure that mental health is on the agenda of the Executive Working Group on Mental Wellbeing, Resilience and Suicide Prevention, and the all-departmental group which supports that, just to reinforce the truth that mental health outcomes are deeply connected and affected by the wider social determinants like poverty and employment and housing and education. So, Chair, that's an overview of where we are, but I think just to finish by saying that, there's an old adage which says necessity is the mother of invention, and I think none of us are feeling that more than now, that really needing to be the case and to pull out the stops in terms of finding creative ways to manage with a lot less money than we need, question every penny of spend, and work really closely with our partners, because the ambition of the strategy hasn't changed. Thank you.
Okay, thank you. Obviously there's a lot in that. There's some positivity, but I mean, there's, I suppose, the disappointment that we have a strategy that's not particularly old, and we're not able to implement that in full. So that is extremely disappointing, given that all of us in this room know and understand the mental health crisis that we're facing. So you have a couple of things I want to come back on. You mentioned the importance of the community and voluntary sector a couple of times there. So, I mean, I don't disagree with you in terms of their importance and the fact that we can utilise the community and voluntary sector to implement aspects of the strategy. A lot of these groups have been dependent on single-year funding. Is there any progress to actually achieving recurrent funding to allow them to plan beyond 1 year and do better work?
Just not at the minute. I mean, we're still in that process, but we are working towards those 3-year budgets.
Okay.
In the immediate future, we've got the new year of the core grant scheme, which will be launched in the coming weeks. And so that will be an opportunity for community and voluntary sector organisations to apply for support. But understandably, that amount of money is finite. Yes. So it's really, really difficult. However, I'm really heartened by the fact that many of our CNV partners have been successful in, for example, attracting COT funding and attracting Peace Plus funding. And there are millions of euros going into really incredibly valuable projects that are all delivering on this mental health agenda. And so I'm just really heartened that we're not completely reliant on the money that comes through our channels. There are other funding opportunities there, and I know our CNV organisations are very good at applying and attracting that funding. But we need to try and do more and ensure that there is stability in that sector. And one of the things that we can do, and there's a few recommendations coming out of the CNV report that EY have produced, and which we will share with you. We're just finalising it at the moment. But even, for example, streamlining procurement processes. Our community and voluntary sector already deliver quite a few contracts for the PHA, for SPPG, for the trusts. We could do more to make that process easier and to support them with that. We know that they are really good at steps 1 and 2 of the step care model. And we need to be thinking as a system, what more can we do with the trusts to get them to pull back from areas that the CNV sector could probably do more efficiently and effectively and locally. So that's an exercise that we're committed to doing so that they have their place. We have a model, it's not the model, it's a model through the Regional Trauma Network of community organisations working in partnership with trusts to deliver trauma support to victims and survivors of the conflict. That model will be evaluated early next year. But it's a model for working together, and there may be others, and we'll certainly look at all of that. But I'm committed, we're committed to that sector really feeling that it is part of this ecosystem that we need in order to make life better for everybody.
Okay, thank you. So you talked about, the target was 35 million, there was 12.3 million available. So what's the spend available this year then?
So it's 5.9 million this year.
And next year?
Well, to be confirmed, but it's probably going to be of the same order.
Right, okay.
But budgets have to be confirmed.
Okay, well, that's extremely disappointing in terms of money. Because I'm looking here at, there was 0 spent on eating disorders against the target of 3.6 million. So can I ask, in a scenario, or in this issue, for example, what's the effect then? Obviously that's an action plan, there was money allocated towards those actions, that's not been carried out. So, what's the impact on people who suffer from eating disorders? Okay,
so I'm going to pass to colleagues to comment in detail on that, but just to say that just because no money has been allocated doesn't mean that things can't be moved forward, and sometimes a little bit of infrastructure funding can go some way towards making a difference. But I'm going to pass to Lorna or Helen. Lorna?
Okay, I'll take that one, Heather. Yes, within the areas of eating disorder and personality disorder, we have had a very small amount of funding, but we've been able to develop a small team, and by that I mean two people who sit within my remit within SPPG, and they have been working on the principle that Heather was referring to earlier around inequity. So they have been working with all of the trusts to ensure that services are operating in a similar way, if not exactly the same, that they have a very clear pathway so that people can access services, and also so that there isn't a significant variation, between neighbours at sometimes, as our trust areas cross different parts of the country. So we have been progressing that work based on a very small investment, and we will continue to do that. So it's really around standardising practice, improving practice, levelling up where there's good practice, and being able to scale and spread that across the region.
Okay, and sorry to interrupt you, but so that's what you're doing with the available fund that you have. What's the difference that you would have done had you got the 3.6 million?
Well, in essence, we have begun to prepare business cases in a number of areas, which would then allow us to develop the services more fully. So to develop the range of services more fully. So for example, to ensure that we have a similar number of staff in each trust area who are working on personality disorder, on eating disorder. So we have and are preparing a business case which would go forward then to be considered were any money to become available. And that would allow us to crystallise, I suppose, on a lot of the work that we are currently doing, but to then make sure that we've got the whole spread and scale across the region to ensure that we've improved the services.
So the money, if we had additional money, it would go to additional staff to deal with additional patients. So, I mean, currently, if we haven't got that, is there an impact on other health services? I mean, because if people with eating disorders aren't able to get the care and attention, I imagine they're presenting elsewhere, so it's some cost to the. I mean, do we have any figures or details in relation to that?
I don't believe we have the breakdown of that. We could provide further additional information after today if that would be helpful. I think it would be fair enough to say that some of those folk that we've referred to, both in terms of those with personality disorder and eating disorder, could be some of the folk who present at our emergency departments, which is why we're working in the absence of funding to establish an improved care pathway so that they could go onto the care pathway then rather than having to go to ED. So they would be some of the folk who would be there and possibly waiting, which obviously we're trying to ensure that we reduce and avoid admissions to emergency department unless they're really necessary and clinically determined. Because
if we're not spending this 3.6 million here in this service, we ultimately are spending money in other services that aren't even the correct services. Absolutely. And it kind of goes against the whole shift left. So, I mean, I think some detail would be useful for us, just so that we can see exactly the lack of investment here, how it impacts elsewhere.
And Chair, this is not a direct answer to your question, but the Centre for Mental Health has done some really interesting economic analysis. They have a report that just came out, I think it was earlier this year, and it analysed the cost of not investing in mental health. And whereas previously we suspected that not investing in mental health was costing Northern Ireland about £3 billion a year, it's actually 3 times that from their latest calculation. And that is taking into account the fact that there are genuine economic costs, there are human costs, and there are health and social care costs, like you have just identified. And so it's an incredible, I think the invest to save arguments, the economic cost benefit arguments, are really clear and no one disagrees with them. It's just, how do we find that necessary resource when we're in the situation where we're trying to find savings this year in order to make the department's books balance. So, for example, if we have currently a spend on services which is £212 per capita in Northern Ireland. 403 million went into mental health services last year. That's the trust delivering their services. If we were to match what England spends, we would need about £100 million more every year, 20% more. And so we need that, and at the same time we're trying to find that as savings in the system. So that's where it makes these are really, really difficult.
And I mean, I picked eating disorders, but there was £200 spent on transition from children CAMS to adult mental health. I mean, I'm not going to ask what the £210 spent. I mean, that's out of a budget of 1 million, but it's a similar type of argument. I mean, I suspect, because even in terms of our next presentation in Respite, we have a lot of conversations here about the transitioning from children's services to adult services. So, I mean, I will ask the question in terms of the fact that we've only spent £210 out of a budgeted $1 million. What is the impact on that on these children transitioning?
I'm happy to take that. I mean, the challenge is that when you work in CAMS, there tends to be a lot of family involvement in the care of a young person. Whenever you turn 18, the responsibility nearly goes immediately onto the 18-year-old, and there's perhaps less involvement. It's just how adult services are orientated. So what we were finding in CAMS was that, you'd have a lot of involvement with the child, they would transfer to adult services, and very quickly they would drop off the radar and then come back to adult services at a point of crisis or when they were more unwell. It's similar to what you were saying about eating disorders, presenting later, more unwell, longer time to recover. So and there's real keenness amongst the CAMS and adult services practitioners to do that differently and to do it better. There's a lot of discussion about whether 18 is the right age to move from children's to adult services. Personality isn't completely formed until you're about 25. Maybe we should hold off until then. So there's a lot, there isn't a very clear evidence base about the best way to do it. So it is an area that we're really keen to look at, because kids do sometimes go off a cliff edge when they leave CAMS, and it isn't in their long-term best interests, but we're really keen that that's one of the areas that we get better at, really, and the £210 was spent on bringing all of the practitioners together to look at what are we doing and what can we immediately do better. We're just trying to make use of every penny that we can get hold of.
Okay, thank you. I'm just going to move. I have some other questions I'll maybe come back to at the end. Colm?
Thank you very much, Chair. Thank you for the presentation, and I think if there's anything that could be guaranteed is if you had 3 times the money, you would be able to deliver 3 times the service, and there would still be more that would be needed after that. It's such an increasing area. There's just a couple of questions, very maybe quick fire even. Just one is, has any consideration been given at all to transformational funding, in the sense that actually, if you were able to use that transformational fund centrally, bring it in, set up a service, it would cause less money to be spent on other services? Has that been...
Yes, actually one of the proposals that we worked up for consideration was in relation to digital mental health, because it's one of these areas where it can have universal impact. What we need in the digital space is a very clear front door for people to be able to go to and get the help and advice. It can be signposting. We could develop it in order to provide even some online service provision that's done elsewhere. So we had worked up a bid for that, but it was competing with many bids, and so it hasn't been successful this year. But yeah, we're constantly looking for other funding opportunities. We're delighted, of course, that the MDTs did get transformation funding, because that very much supports the agenda. So,
if I could come in, we do have one for family support.
Oh,
and I mean, I know it's early. It's very much in the early intervention and prevention space. But the more we can support families, the more we can support the emotional well-being of children, the better the outcomes are going to be in the future. So, I know that one has got through the first stage. So we're very well, fingers crossed.
I'm glad to hear, because my former role as a youth worker, we used to, in our building, host the family support hub going back maybe 10 or 15 years ago, which was an early pilot of that, and you actually could really see how agencies could come together around the table and provide that help and support, maybe sometimes by just simply saying we can do that, rather than actually being money that was being spent around. So,
and the bid is really about, we have universal coverage of the family support hubs. It has been such a success, Colin, that the bid is really to just enhance that and supercharge that, because it has worked so very well.
And we would completely support that, because so many of the areas of the work of the Department of Health reinforces the others, and so that's an example of one, so we'd be entirely supportive of it.
Yeah, and there was loads from education and there that were then saying that they could provide evening packages or afternoon packages that were often supporting people to maintain at home as well and providing outlets. So that's a good model to...
And one development that we have been able to do, which is at low or no cost, is we now have primary mental health workers on all of the family support hubs. So they're able to pick up immediately those cases where they're able to provide, that emotional literacy, emotional wellbeing support for families. So. And
the savings long term down there are absolutely massive because of some of the early interventions that go. You mentioned the MDTs there. Is there any work that goes on? Because obviously I think at this stage with the new transformational funding that was bid for the MDTs, that brings us up to, is it 50 or 60% of practices that have it, so there's obviously an area that don't have it. Is there any way in something as important as mental health that there can be services directed into there so that they get at least an opportunity to bid into something even if they don't have an MDT where it's sort of a standard practice?
Well, I mean, from the CAMS perspective, we've mentioned the family support hubs already. I mean, our plan is that we will have full coverage of MDTs in the next 7 years. And so that's being done in 2 phases. So we're completing the 5 that we already have, plus, so we have it in 7 areas. So we're completing the 7 that we already have, and then completing another 5 areas in phase 1, and then full rollout in the 2 years after that. So obviously we're building the workforce and building the expertise as we go along. Part of that is social workers who will be able to work with children and families in the emotional wellbeing space, and then the mental health practitioners who will work across the lifespan and also link in with the CAMS and the team. So I mean, that's the future, and it's really bright, and it has worked really successfully. So
and we could work with the community and voluntary sector to look at, well, where are the areas which are less likely to have MDTs? What's the path there, so that we try and bolster provision in those areas. Because I take your point about inequality. Yeah,
and it fires up, especially in areas like Belfast, where South Belfast doesn't have it, but East and West now will have it, and therefore just depending, you could be living in the same street and not getting access to services from others. So it could help.
Absolutely would help. Absolutely would help.
The final thing was there about mental health and older people and strand that out. And I know that a colleague of mine previously had the all-party group on loneliness, and I've met with U3A and I've seen the work of all of those community groups that are providing work. You think of men's sheds and other types of initiatives where, like, tiny amounts of funding, like a men's shed, £5,000 a year for one could allow them to exist. But they were saying about if they had their infrastructure, they could link in with other sectors, like maybe bring a nurse in to talk about blood pressure or to talk about prostate cancer, and taking something like that. And I know that money is scarce all around, but it's amazing sometimes when we think, goodness, £100,000. And they told the story, the one in Rostrevor that I visited, of the nurse that came in and one person was detected with prostate cancer, and that difference was from finding that person at stage 1 versus that person maybe arriving at stage 3 or stage 4, and it could have cost £100,000 for their treatment. So again, in that sort of transformational spirit, is there something there is that the type of thing that you would see with the voluntary sector?
That's exactly the type of thing, and that's where, and we're just really conscious that we haven't put a focus on mental health in older people, nor at the other end of severe and enduring. That's why they've come out as priorities to focus on, and so that's exactly what we're going to be looking into, to see what more can we do there, and how can we inject a little bit of resource in to make a disproportionately positive
massive difference.
Yeah.
That's all very positive. I know groups in my area would absolutely be loving to hear that, so hopefully we'll be able to develop on it. But thank you, Chair. Thank you.
Oh, thanks, Chair. Thanks, Heather and team. You spoke glowingly about the recurrent funding and the benefits that it brings, particularly to early intervention and prevention, and you also spoke very glowingly about the C&V sector, and that's good. It's good to hear. However, when you look at organisations that are at the heart of communities and within neighbours, and we talk about this neighbourhood model, and I want to just talk about the Crisis Intervention Centre in Foyle. There was an organisation that was at the heart of that community, embedded within that community. Yeah. And on one hand, they hear of the importance of the C&V sector and of organisations being embedded within their community, and here was one, but yet those shutters had to close there. Yeah. So how do we prioritise what funding goes where, particularly when you have organisations here that are helping thousands at the absolute cold face?
Absolutely, and especially when a service has been in a community doing a really valuable job and has established its value, then for the funding to run out is a real blow for all concerned, and we are as concerned and anxious about it as everybody else. I mean, that mental health support fund, we were so lucky that we were able to use it even for that period of time, because it was COVID funding which was repurposed, and so it was always going to run out. And then just again, it's in light of this bigger context. And at other times, in other years, we might have been able to have cast around the department's budget, found slippage, been able to do things, but it's because every penny has been taken back to the centre in order to try and meet the deficit. That's why this year is particularly hard, and there's been no latitude for trying to extend funding, although I think in relation to that case there has been a little bit of an extension of the funding for a short period of time than had originally been planned. So yes, completely take the point, and we have to try and just find opportunities where we can support the community and voluntary sector in terms of identifying other pots of money to be able to apply for. And the core grant scheme is one of those. It's a small one, but at least it's there and it's going to run next year.
I mean, we all find it incredibly sad that organisations such as that and many more, I mean, every year they're having to beg for survival. And I find that incredibly sad. And we've debated it, time after time on that floor, and even those before me. And I suspect yet again, in the coming year, we'll be debating it yet again.
Thank you, Linda.
It is sad, and it puts pressure on the other services then that are around it. And I know colleagues who work on the regional crisis service they're very acutely aware of that.
Linda.
Thank you, Chair. The two things that I want to talk about, neither of them really require additional or any significant additional funding. So, and you've kind of mentioned both of them. So the first one is pathways, because I think there's a major problem there. And, even where there are services, it's understanding what is that pathway. And that is actually costing us money. So, I mean, I've had a number of cases where I've been dealing with families and trying to figure out and navigate how somebody doesn't have to be repeatedly picked up by PSNI and brought to A&E with PSNI officers, only to be put back out of A&E, to end up back in A&E, to eventually end up in Bluestone anyway, and have already been a patient in Bluestone. They're known. And in one really serious case where that person almost succeeded in taking their own life, but was left totally incapacitated and taken up an ICU bed for months. Now the cost to the health service, and that's only one. So there are numbers of cases, and that's where it was identified as a personality disorder. And I'm not sure that it was a personality disorder, but that's what it was identified as. But there was no pathway, and there still isn't. A person's back in bed unit, and there isn't. We haven't been given a clear pathway as to what would happen, if she comes back out into the community to be treated in the community. Then what happens if there's another crisis? What's the clear pathway? I would say at this moment, they'll end up in the same position. That individual ended up in prison in Hydebank at one point to protect themselves. It was the only safe place the PSNI could bring them to. Now that is horrendous. That there is no pathway, and that is someone who's extremely ill, and a family who are actually end up suffering their own physical and mental health as well. So, and as I say, I'm only talking about one incident there. So, the pathways is a big problem. We can talk about pathways into this and into that, and out of this and out of that, but I really struggle to see them whenever I'm dealing with families. I really, really struggle to see what are the pathways. So I suppose that's the first one, and the second one is what we discussed. there about the community and voluntary sector and what's available out there. Trust provided, community and voluntary sector provided, other statutory agencies provided. We do not have one database where you can find out what is provided, where, by who, and again, what's the pathway, how do you access it. It's, if you're lucky enough, somebody knows about it and you're long enough in the tooth like me, and you've been about and around enough corners that you've probably heard of most of the organisations in your own locality, and you're able to signpost people. But I'm not a professional, so am I signposting them to the right place? You know, I'm not. I don't have the skills or the expertise to know that I'm signposting. So you're doing it and you're hoping you're doing the right thing, but you don't know if you are. So those are two things I think that need to be done. And I know there's something I can say. I was at a meeting probably 10 years ago in my locality, and it was asked for then, just for our own local area, or preferably for the Southern Trust, but for our own local area, and I've never seen it. So community came together and tried to put something together, but I mean, that's not the way to do it.
I start on that one, and colleagues cover pathways.
I can do that, Helen. Yeah.
Okay, so I think that was the driver around that digital bid, to create this one-stop shop where you basically can go in and find a search by your area, what's available, what according to what you might need. In the absence of that, I mean, we do have the Minding Your Head website, which the PHA run and service, and that sets out to be a signposting resource, and that's just recently been refreshed, but it needs to be, it needs resource, you know, because these information like that's only as good if people keep it up to date. And so it does need a bit of resource in order to focus on that and to constantly develop it. I mean, the good thing is with the MDT rollout, there will be practitioners in those practices which at least know the local environment and will be able to refer. But totally take your point, that's one that's in those limited areas. We need to think about what we can do more generally, and that's where that sort of region-wide or Northern Ireland-wide provision will help. I mean, we're committed to looking at that, and I'm very happy to go back to the PHA and just say, is this as good as we can make it? How are we keeping it up to date? How do we raise awareness of it with everyone so that at least they know there's that they can go and search in the meantime? I don't know, have you had any experience of looking at it?
I actually haven't.
Okay.
I'm perfectly honest, hold my hands up, I didn't know anything about it.
Even that, it's raising awareness.
Yeah,
that
so
exists.
I think that would certainly be useful. I mean, the very, very least to get that out to elected representatives, because we would then forward it on out to our community groups and organisations and local groups that are working with vulnerable people. So do you envisage that, I mean, the transformation piece, the digital piece, how would you gather the information? So obviously you have a fair bit of information in terms of what you're talking about in the website, and I will go on and take a look at that and just sort of try and get a sense of how good it is, how useful it is in my locality. But would people have to, you know, would organisations, groups, because you're going right down into the very basics, you know, of like groups that just walk for your mental health, walk and talk, those kind of groups. Would all of that be on that? And would they have to register, or do you seek them out, or what? How does that?
Both. I mean, we would be aiming to develop something similar to the Family Support NI website. Have you been on it? Yes. So it would be the same. So you can either go by what it is you're looking for, if it was, you know, anxiety or depression, or by what's available in your local area, because that's what we've done for children's. But it's dependent on somebody keeping it up to date and keeping it running, and the organisations being very connected into it to make sure that it's live. But I mean, you know, we have looked into quite a number of these platforms which can signpost information, can provide you with written information, or can actually link in with a clinician. You know, so in an ideal world, I mean, you've probably heard the adverts on the radio for better help and stuff. I mean, in an ideal world, that's something that we would like to be able to provide, because it is available in Wales and it is available in the south. You know, where you can nearly, it's like self-help, but it's self-help nearly taken to extremes, where you can speak to somebody and you can have CBT online if you're feeling low. I mean, that's where we would like to get to. That's part of our digital plan, but I mean, we're far away from that at the minute. So it is about how we can just be as organised as we can be and as efficient as we can be at the minute.
At least get information out. But that's one of the things as part of that early intervention and prevention action that PHA lead on. They do have resource in there to do communication, and so they can keep that up to date, and so I think in the meantime, until we have something which is the true one-stop shop, we should at least be making more people aware of it, so we can do that.
We also have a digital apps library that was it was set up during COVID because it gave people access to apps and things where they could, for self-help essentially. So, we're still very much wanting to see that promoted more widely. I don't think it is well enough known at the minute, but it's a really good resource, because the key thing is that the apps on that library they've been reviewed, and they've gone through a review process to ensure that they can be trusted and they're robust. And I think we're very keen to promote that more widely, just so that people are aware of it.
Okay. And then the pathways, which is the big one, because
I'll pass over to Helen then.
I'm probably talking about more people who are really on the worst end of the scale, to be honest with you.
Absolutely, and we understand your concerns and the experience that you've outlined. We're acutely aware that there are inconsistencies across the region in terms of the pathways, which is why, with the very small resource that we've been able to have around personality disorder, eating disorder and crisis, that our focus has been on the pathways, because we feel that's somewhere where we can do better with what we have and try to look at how we align that. How do we get agreed and consistent pathways across the region, but also how we can raise awareness then of how folk and where they need to go. So what the process would be and where the contacts would be, and how we could avoid people going through the cycle that you have described. Helen, my colleague here, has been working most closely on the crisis pathway and has a draft pathway in place. So if you'd like, Helen could give you a little bit of detail around where we've got to with that one.
Yeah. So from the point of view, we're looking at a regional pathway for Northern Ireland. We're looking at it being a lifespan model, so that it encapsulates all of our population. We're also looking at it going across all sectors, so that individuals from community setting who are in emotional distress will know where to go, how to get help, where that help could be. That could be in their local clubs, it could be in the local farmers union, it could be anywhere, but how they get help where they need it and when they need it. We want to support people that are in mental distress and emotional distress, that are not necessarily always mentally ill, but if that distress is not supported and navigated right, and the life skills that people require to be developed in order to sustain a healthiness, if they are not put in at the right time, it could lead to mental illness. So we want to try and have the right supports at the right stages in people's lives. We have a pathway developed. It is still in its infancy and is still open to a lot of amendments. It looks right from the community and voluntary sector, primary mental health, how then you move into level 3 services, tier 3 services, what you get there, what is needed there, how we have the right pathways, we have the right referral processes, we have the right sharing of information, and then how you move into acute services and flow back out again. We want to have a regionalised service, so that if a person lives in one geographical area and they become unwell and they move to family in another geographical area, that they're not pushed back and forward, that we know exactly what it is. The Encompass system has undoubtedly helped that, because we have the regionalised information sharing, so hopefully that will assist us also. But to ensure that no matter where you live in Northern Ireland, where it's an urban, rural, a coastal area, that you know the services that are available to you, right from the primary mental health, community voluntary sector, right up to acute services, and you know where and how to access those, and that you also know the response you're going to get there. So our services, there's a lot of inconsistencies throughout Northern Ireland in how services are delivered, how the pathway is, what the threshold is. We want to ensure consistency around the region. We want to ensure consistency in public messaging also, as we've already heard, Mind in Your Head, fantastic website, it links across also, and the family support links across, where we have the apps library. That is not an alternative to other supports, but it is something to support. It's something that the likes of yourself, myself in practice, we can refer clients, people, citizens to that. We know that it's a safe, informed, evidence-based set of apps that will really support people, that they can link into. They can use them at 3 o'clock in the morning, they can use them at 4 o'clock in the day. They're there, they're available, they're immediate. Our staff can refer people to that there. Whenever our health and social care staff refer anybody, we can track that. We can track the access, and the evidence is anybody who's referred to the apps library, there's a much higher success rate in actually using those apps to promote their well-being, to keep themselves well, to get by until maybe the next morning at 9 o'clock when they can go to see their GP, when they can go to see their home treatment team, when they can see other services. So we're looking not only at small areas, but right across the life spectrum of people and right across all of our service areas and our region.
When might we see that pathways plan, what it looks like, and is it something that's being discussed at the committees in common? Is that the vehicle that's being used to for the trust to agree that this would be the regional pathway, and they're all going to buy into it because that's what
all
we need?
trusts are involved, all stakeholders are involved.
Okay.
We also have representation from carers and those with lived experience. So we hope that once we get it, now it still is very much damp ink, and there's a lot of work to be done to it, but we would hope that once it is developed that everybody has bought into it, everybody has engaged in the development of it, so therefore the expectation is everybody will buy into it. There's a lot of work to be done with it yet. There's so much work to be done in the relation to crisis world that it can't all be done in one sweep. So we're doing bits and pieces as we go along. The area we're giving a lot of focus on at the moment is our liaison service and our home treatment services. We see the home treatment service as pivotal to offering acute care at home, to reduce admissions, people that need to be admitted to hospital, to provide care in a person's home. It's a fantastic option. Once you go into a psychiatric setting, there's a lot of instability, there's a lot of movement, a lot of noise, unpredictability. That doesn't always favour recovery. So we want to see where we can level up our home treatment service to provide 24/7 service. There is some areas we have that, there's other areas we don't, so we need investment to finance it to level that up. A lot of trusts are doing really exceptional work at the moment to try and use what resources they have to spread the service as broadly as they can to provide the service that people need. Our liaison service also, we are looking to try and follow, or we are following the Royal College of Psychiatry standards for liaison and for home treatment, so that gives us a benchmark where we need to be and where we should be. Liaison service also across the region in our emergency departments is not 24/7, so we need to look at how we can develop that so that people who present with a crisis to or a mental illness to an ED department will get prompt support from mental health practitioners, so that aspect of the care is dealt with, treated, and that the next aspect of the care plan can be developed and agreed, rather than them sitting there potentially seen at 6 o'clock in the afternoon, medically declared fit to leave, but there's a mental health aspect and maybe have to wait the next morning at 9 o'clock. We don't want that for our service, and we don't want that for our citizens going to those departments.
Thank you, Chair.
Okay. I'm on the website, very, very useful, by the way. And I actually had heard about it. Unfortunately, there's a number of suicides recently, and we had a number of sort of events, and the PHA were there, and they had mentioned it, so it is a useful tool. Danny?
Thank you, Chair. When I was reading this, it did strike me, and we're all aware that the strategy isn't being funded, and we've heard time and time again. It's appalling. It really is shocking and a disgrace that it isn't being funded. It was announced to huge acclaim that we were setting out our stall for improving mental health in Northern Ireland in 10 years, and here we are nearly halfway through, and we haven't been able to do it. It just strikes me, I know people come to my constituency and everybody else's, I'm sure it's the same, that are suffering mental ill health on long waiting lists, and not just stable on waiting lists. They're deteriorating. They get sicker and sicker, and then by the time they get seen, they've got to a sicker point whereby they're going to need longer treatment, they're going to take longer to recover. So this is a spiral. It's kind of led me into something that you mentioned there. I just wanted to check with you the cost of mental ill health to Northern Ireland. Now certainly the figure that we normally see attributed to this is a PAC report from 2022 where it's 3.4 billion.
Yeah.
You said recently there's a report.
Much more recent one, the Centre for Mental Health, which it's based in England, but it is a UK-wide remit, and they said that the economic cost of not treating mental health appropriately for England was 300 billion, which when you do a Barnett formula, it works out about 10.5 billion per year for Northern Ireland. So it was because it has taken into account a financial formula to take account of the human cost, as well as the cost to the health and social care sector, as well as the cost to society. So economists have looked at that, and that is their assessment of it. So it's worse than we thought. So that's what I mean. The arguments for investing in it are really clear, and no one is questioning them.
That's incredibly shocking. Now, 3.4 billion a year is shocking by itself, but telling us that mental health in Northern Ireland costs 10 billion a year to our local economy here, that is an incredibly shocking figure to hear. And certainly I'll be going to reading that report, and I think that's something we should all should be doing. You mentioned workforce in the early part of your presentation. Workforce is an issue that we get raised here time and time again. Every aspect of the health service is huge issues with workforce. You also mentioned the community and voluntary sector, as including community and voluntary sector as part of it. The two main actions in your update cite Action 17 and Action 32 about strengthening the mental health workforce. Yet, according to the figures provided, both of those actions have only received around 1% of the recommended funding.
Yes.
So while workforce is a key important issue, they're only getting 1% on those two key actions.
Yeah, that's right. We just have not had a resource to be able to do anything other than the planning and preparatory work that you would need to do more. So, for example, July 23, EY produced their report, which set out a very clear set of recommendations as to what needed to happen for the statutory side of the workforce. At that stage, it was considered, and I think this was right, that it would be too big an exercise to include all of the C&V sector within that one envelope of work. And so we commissioned a separate exercise also from EY earlier this year, and that report is just in the process of being finalised. And so that looks at the scope and capacity of the C&V sector to really be fully integrated. So that it's going to take significant time and definitely resource in order to make a difference. But there are things that we can do that don't necessarily all require resource. So, for example, at the moment, there's a huge shortage of psychiatrists right across the piece, but particularly in Southern and Western Trusts. There are funded vacancies, so it's not a financial issue. It's how do we get psychiatrists to come to Northern Ireland? How do we make this an attractive proposition? And the difficulty is that you get into this doom spiral where when people are in a role and for whatever reason they don't have enough colleagues, the pressure is on, then it becomes not a nice place to work, and their experience doesn't encourage other people then to come. But we have to find a way through this. And we've got Professor Rooney now in as interim Chief Psychological Professions Officer. One of her tasks is to look at the potential of the psychological professions within our mental health workforce, because there's a huge range, ranging from psychotherapists and CBT practitioners to counsellors, and there's massive potential there, I think, to do more and perhaps to take some of the strain from the psychiatry, but being cautious of boundaries with the steps.
But also, building nurse consultants, nurse prescribers, advanced nurse practitioners. I mean, we've had great success with a small number of them in CAMS, and keen that we build as broad a base as possible, and make the best use of the money that we do have if we're not going to get more. So how we build those roles, how we build pharmacy, and how we make use of AHPs, how we broaden the base of mental health. Until we can get enough psychiatrists, until we can have enough clinical psychologists, are we stretching?
As much as possible.
Yeah.
Community voluntary sector, it is, and we know that they provide vital support across our communities. That they are the groups that are on the ground and are delivering services. Yet, whenever there's funding cuts, they seem to be the first ones to lose their funding. Many of them feel unstable, many of them feel insecure, many of them worry when it comes to this time of year in particular, to see what their budgets are going to be. You mentioned the core grant scheme as well. The core grant scheme initially was 3.6 million and then reduced to 1.8 million, so it was halved, and a lot of services lost out, and then they changed the funding and a lot of other services lost out. Do we know what core grant funding is going to be next year?
I think it will be of the same nature, but I can't confirm that. I think it will be similar to this year,
And,
this current year.
similar to 1.8 million.
Yeah.
And just another question about ADHD services in Northern Ireland, completely non-existent for adults. Many people who go and find private diagnosis, then they face big issues trying to get either shared care or having to pay private treatment in order to get medications that they need for a condition that they have been diagnosed with. Are there any plans then to improve pathways, to deliver a service, and to have a service available for these people who need it?
Pass to maybe Fiona, who's leading on the ADHD needs assessment.
So we are very mindful that there is, there aren't commissioned ADHD services, and it's something that we're very keen to establish an evidence base in terms of what we do next. So we commissioned a needs assessment in February, and that's looking at what the demand is across the lifespan. It's for children and adults. But then looking at what the proposals would be for pathways, what the service would look like, what the implementation costs and staffing costs would be. So it's a really important piece of work. It's ongoing at the minute. We're hoping that it'll be finished by the end of next month, and that will hopefully then just set out what the recommended scope and scale and sort of staffing requirements would be for an ADHD service. Now, we're very mindful that that would require additional money, but we want to be in a position that we can make, and the Minister can make, informed decisions around what a future service might look like. But it is something that we are very keen to establish what the need is.
Okay, thank you. I know we have a lot of people, and certainly in my constituency we would get a lot of people coming.
Annie, would you mind if I
No,
come in just on that particular point? So, are you? Is there any thinking yet on whether that would be trust specific or regional? And I'm not saying that to try and catch you out. Oh, I want it in my area, because I don't. I want a service. I want a service for everybody, because, like Danny, I've been inundated with people who've went privately to get diagnosed, to get the medication in place, and then they can't get the shared care arrangements put in place with GPs. And honestly, I don't blame GPs for that, because they get no cover from the trust. They're taking that on their own risk, and taking it on from a private consultant. They have no guarantees that that individual's going back for their checkups and that they're getting all the information they need. So that's a big risk for them to take on. So are you thinking trust specific? Are you thinking regional? Or is that? You may not be able to answer that today, and that's okay.
It's all in the mix, but we're looking at what's required on a regional basis. It's not in any one particular trust area, but it's also looking at around sort of the sort of step up, step down type model in terms of where's best placed to provide that support. Does it need to be focused on specifically on sort of specialist psychiatry type support for somebody with a diagnosis for ADHD, or are there other professions that could help supplement that? But recognising that it's wider than just it's not a condition you're just talking about medicalisation. There are other supports that are needed there, so that's all in the mix in terms of what that might look like.
All right, Danny, thank you.
No, you're right. It's a very good question, and certainly it'd be one I'd like to answer as well. So, just one last question. We were talking about eating disorders. Binge eating disorder is currently the second most popular eating disorder in the UK, yet isn't recognised. Recognised by NICE as the UK's most second common, but is not currently treated as an eating disorder, and data, as I understand it, data isn't collected by the Department on binge eating disorder. Untreated, it can lead to other issues like obesity and the health problems that then come around that. Higher risk of stroke, heart attacks, cancers, type 2 diabetes, and all the other things you can imagine. Just where do you stand with binge eating disorder? Is that something that you're looking at? Is that something that you're looking to treat?
We'll maybe need to come back to you with information about that.
Okay. And just in line with what Phil was saying about the connection between eating disorders and then other conditions, you know, how they relate to each other, risks and how they may end up being treated. Thank you.
Okay, thank you. Arlia?
Yeah, first of all, I feel like I have to apologise that my face is coming up on the screen. I'm really sick with a cold, so apologies everyone that you have to look up close to when I'm not feeling well. Sorry, I feel like I should be apologising for that. So yes, I just want to say I'm conscious that the issues that we're touching on today around mental health. So we're talking about obviously a very, very wide range of areas and services. And it's great to have you all here today to give us a different briefs in terms of the particular areas that you are working on. But I just want to maybe ask some specific questions to tease out of your briefing. So Heather, I know, and most members have touched on it already, I know you had says in your opening remarks around so that workforce has been identified as for 26-27 for one of the top priorities, and that's including the community and voluntary sector. So, I mean, basically the question is, what can the community and voluntary sector expect out of that statement for the next financial year?
Okay. So we've already been in discussions with the Mental Health Collective about the EY report that I mentioned, which is going to be finalised and published. And I have offered them the opportunity to co-chair a task and finish group with me in order to progress the recommendations that are in that, which is all about how to progress integration of the community and voluntary sector into the workforce. So I am really looking forward to starting that process with them, and I know they're reflecting on how they want to engage with that, so that we can really start to make inroads, and we can work out of all of the different recommendations that EY made where they feel the priority should lie, where we place our focus, and how that complements then the work that we're doing on the statutory side of the house, which is about looking at how to cost the workforce profile that was identified in that EY report, and how we do a service prioritisation exercise so that when we do have funding, we know where we need to recruit people to, where's the areas of greatest need, greatest priority, and we will try and bring that all together. So basically what I'm saying, I think, is that I'm not setting out anything which is a firm path that is not co-produced by the sector themselves. You know, we're not going to do this onto them. I need their engagement to help us work through that, and I really want to do that and start now.
Okay, so, and that all sounds really positive, but so co-production is already and should already be in place, and regardless of what work we're undertaking with the community and voluntary sector, I know it is already in place with them. But in terms of then identifying that particular sector as a priority, it's been identified as a priority for 26-27. I'm not really sure what is coming out of that, you know, outside of
Exactly.
you know, the group around the integration and stuff.
We have to work that through, Orlia, and just work out what can we do with the resource that will be available to us in 26-27. So,
okay. No, and that's fair enough, Heather. I understand that. But I also think that it would be useful in the spirit of co-production to maybe consult with the community and voluntary sector prior to whatever decisions are going to be made, to make sure that whatever way the funding is going to be spent is spent in the best possible way. I think it's important to do that, because I know Danny had made the point around the core grant scheme obviously being halved, and it's your understanding that next year it's still going to be sitting in and around that 1.8 million. And that scheme was a lifeline to a lot of the community and voluntary groups. So it's just to make sure that even at this stage that we're getting this sort of balance right, you know, before we set out to do a piece of work with the community and voluntary sector, that they feel content that in terms of how they are prioritised, that it's suiting their field of work. Do you understand the point that I'm trying to make?
I do absolutely, and I have incredible empathy for it. I worked in another life for 5 years in the voluntary sector, and so I have an absolute passion and commitment to what they can do. I've seen it, I know what they can do. So it would be really remiss of us if we didn't bring them to the table and be genuine partners in this. And so that's what I want to do.
No, that's great. Thanks very much, Heather. And then my next point was around, so the digital mental health platform, so that's been identified as a priority for 27-28 alongside older people. And my question around the digital stuff, and I know there's already been some conversation around how that can help and assist people with poor mental health or mental illness, and like navigating the system, or you know, maybe in supporting them through online mechanisms. But I'm just conscious then, if that's been an area that's been identified, considering all the other areas, difficult areas that you have to try and deal with and make better. Can you just explain a wee bit more what this digital mental health platform means? Is this, you know, is this moving more towards making more treatments available online, you know, more access to apps? Because certainly my experience as an elected representative for the past 8 years in West Belfast, and as the party's mental health spokesperson across the north, in any families or individuals that I've been dealing with around all of these wide-ranging issues around mental health, addiction, substance use, I would not identify digital. I'm not downplaying their importance, but I wouldn't identify that as a priority on behalf of the people that I have been working with. The priority for them, and this is my experience, I'm just speaking about my own experience, but the priority for them is trying to access frontline services, it's trying to access crisis services, it's trying to access rehabilitation for addiction. So just maybe some feedback on what that digital mental health platform will mean and why that's being prioritised over other things.
So digital generally, I suppose, is one of those areas where we felt it would have more or less universal reach, and to try and improve that level of signposting and lower level support for everyone, which is particularly valuable, I think, when you're on waiting lists, that there's something there that you can engage with, whether it's a little bit of self-help or hopefully developed in some as part of this to create actual service provision, engagement with the apps, what have you. So because we've tried to balance in setting priorities that sort of universal or bigger population focused actions together with not forgetting about some of the smaller but high need vulnerable groups like older people, that's why we have settled on those. But it's also come as a result of the conversation with the stakeholders that happened. So those were the areas that came to the top. But you know, I agree with you, because the mental health strategy is all important. In some respects, it wouldn't have surprised me if any of the actions had come forward as being they are all priorities. They all should be priorities, but we've had to choose just where the focus should be. And I think we were thinking that in terms of trying to maximise the reach, that the digital would really help to do that. I'm going to ask Fiona just to comment more on the work to establish the digital mental health action plan and just the various components of that, because the platform, or the platform was the subject of the transformation bid, but actually there's a lot more that we can do besides.
So as part of Action 30 in the strategy, there's a commitment there to develop a digital mental health model, and the focus of that is about increasing access and accessibility to give people greater choice in terms of how they access services. So we established a digital mental health forum about a year and a half ago, and there's been a large piece of work being progressed through that to develop a digital mental health action plan. So that's about identifying what the key elements of a digital mental health model should look like. We've already talked about the platform, we've talked about an apps library, but it's broader than that. It's about looking at how we address things like digital exclusion, how we support people to get more access, how we build trust in the use of digital services, because, the work that we've done has been very much informed by engagement with service users and carers and clinicians and other regions in terms of what they're doing. And I think that's an issue that has come up repeatedly, is in terms of what are people going to do with my information. And so we want to develop a model that addresses all of those points. So we have a first draft of a digital mental health action plan that is nearing completion. It needs to sort of be shared with the forum members to sort of critique it and just see if there's any gaps. But where we want to get to is that we have an action plan where if funding becomes available, and hopefully it will, that we're well placed then, that we know what the need is. But there's lots of things in the digital space around, like the use of VR and wearables that that monitor people's conditions. So that there's loads of really exciting things that we can do in this space, and I really do think Northern Ireland has the opportunity to be a bit of a forerunner in terms of how we adopt some of this. So it's a really positive action, I think, in the strategy, because there's loads of opportunities that we can tap into there.
Yeah, no, thanks very much for that. And I obviously appreciate all of your expertise, because you are experts in this field. I'm not. But I would just go back to the point around, particularly when budgets are so tight and yous are dealing with a very modest pot of money, considering everything that you have to try and do and deliver around mental health. I would just bring it back to, how then we're monitoring the outcomes in terms of people who are actually already at crisis point, already battling with addiction. We know that, it's already been well covered that drug deaths by alcohol, all on the rise. In fact, it's the largest inequality here in the north in terms of health inequalities, deaths by drugs. So although the digital stuff sounds exciting and innovative, I would just be concerned that, like in the briefing paper, it was saying that, I'll take the example of addictions then. So there was a regional rehab service, rehabilitation service, quoted with no investment, and I'm not sure if that's mental illness rehabilitation or if that's specific for addictions. But then in relation to addictions and the co-occurring mental health and substance use work, so in the past 3 to 4 years, there's been £70,000 that's been spent towards that, although for me that would be that should be a huge priority. And it would certainly be, it would benefit of additional funding, considering that the drug deaths is the largest health inequality here in the north, and we know that people are losing their lives from it. So it's just, I'm just trying to understand, when these priorities were set over the next 3 years, how it is decided that one is taken priority over the other. And so yeah, maybe just a wee bit of feedback on that around the addictions investment. And I know some of that's separate and falls under the substance use strategy.
That's just what I was
it all
going to
crosses
say.
over.
It crosses over, but absolutely, because there is a separate strategy focusing on substance use. And we do have Action 28, which is about dual diagnosis, and I know that colleagues have been working on that. But it is because there is a separate focus on addictions that we have, yes, that's the rationale.
Do you want me to?
Okay, and well, that maybe brings me on to my next question then, just more broadly around the mental health budget. So when I'm talking about the budget for mental health, I'm obviously talking about mental health, suicide prevention, and drug and alcohol addiction. So I know, Heather, and we all completely understand, because we've heard it from the Minister, we've heard it from the Permanent Secretary, we hear it week in, week out at the Health Committee. We understand the pressures that the budget is facing. And but the question that I would like to ask is, because it has been said, multiple times around no additional funding, and sometimes that's directed towards the executive. And were that right to make that comment, then we would all support that. The mental health strategy, we know some of these things are signed off executive wide. But essentially, and I have made this point to Robin Swan before Mike was in place, the health budget is the responsibility of the health minister. Okay, so even setting aside the mental health strategy, when health receives its overall budget, is it the case that mental health is still only receiving 5 to 6% of the share of that very large budget?
Yes, yes, that is the simple answer to that. And it becomes really, really difficult to have conversations about moving budgets around, I think, when the overall amount is not what's required to break even. So that's what makes it really, really difficult. If we had sufficient money to break even across all of the programmes of care, it would be easier to make arguments around shifting funding. But when everyone is looking for savings to the extent that we're looking for them this year, it's really, really difficult. Those arguments have been made. We constantly raise the importance and raise all of the the rationales that we've discussed previously this afternoon about how important mental health is, and that message is clearly understood. But in terms of priorities around what would be cut in that case, these are incredibly difficult decisions for any minister to make.
Yes, no, I completely understand that. I really, really do. But it's maybe just to make the point that you have mentioned, Heather, with that latest piece of research. It was already talked about around the addictions alone costing £900 million a year to our economy. And you had just mentioned then that much larger figure around the cost of not treating or not dealing with poor mental health, that 10.5 billion a year to the economy. So is, I would imagine, with that latest research and that figure now that's being quoted today, £10.5 billion a year, that's the cost of the economy in terms of what we're not doing right around mental health. Is that a live conversation in the department at present? Because and surely for yourselves as a team, I know you're all doing your best, but that would be your pitch to be bringing to the leadership to say, I know that there's not enough money at present, but that 10.5 billion a year, does that not make the case that even if we were to get that 5-6% up, as I said, we've been talking about this for years with successful health ministers, if we got it up any would be a help.
Absolutely. No, that point, Ciara and I have made
preaching to the converted.
Absolutely, we have made those points at the highest levels. Yes.
Well, look, we'll certainly. As a health committee, all of your information has further enlightened us today. So we'll take all that on board and keep making the case for you also. My final question then was just around the regional crisis service, because I know that is a very worthy priority that everyone's been working on. And just then, in the briefing paper, it had listed, so some of the action points that you have been able to deliver in the regional crisis service. The mental health liaison pilot, the multi-agency triage team, the hear and treat, and the community navigators. But outside of that, so all of those projects, and they're very, very important pilots, and hopefully we'll get to see those expanded right across the 6 counties. But outside of those, because they're not really new projects, no. So we've been those. I think those pilot projects have been in place for a number of years. That would be my understanding anyway, through written questions and verbal Q&As with the Health Committee. So on top of those projects, I know there was updates around reports and workshops and rapid reviews. But for the regional crisis service, what can we expect to see substantially delivered on that over the next financial year, or the next 2 or 3 financial years in your plan?
Yes, well, I'll offer to come in on that, and that can be supported by colleagues. From the point of view of the service, we are short of money to do what we want to do. As I explained earlier on, it is lifespan, it is right across the sector, right from community and voluntary sector right through to acute services. We want to see what we can do, so we want to stabilise and see where we are and then move forward. The actions we're working on at the moment, as I've already explained, is a clear and decisive pathway for our area of Northern Ireland. It is still a work in motion. We have engagement from community and voluntary sector. We have engagement from those who live experience, carers, and right across statutory services. So we will be working on that as we go forward. Can I give you a timeline on when that's going to be definitively agreed? No, I can't do that at this stage. There's a lot of work to be done. We know where we are with the statutory sector services. We know what we have. We can't predict what we're going to have going forward. It's about building on those services. It's about creating those clear pathways. It's about providing supports and ensuring that there's a regional consistency and equity of service delivery. From the community and voluntary sector, I wait and embrace the EY report to look at the scale and scope of our community and voluntary sector. That is going to be pivotal to our population that are in mental distress, that are in mental crisis, that they need the treatment, they need a very rapid response, they need to know where to go to get the right support. That support could be short-lived support, it could be longer planned interventions. We are working on that at the moment, and we need to get there, and that's where we need to provide a lot of support to our individuals to let them develop life skills to deal with crisis, because crisis will come and go. Crisis come and go in all people's lives. It could be something that for others may be fairly trivial, but to the person who's experiencing that, it's quite serious and quite severe. So we need to get the right service to the right people at the right time to support them to develop life skills, because crisis will happen again, unwellness will happen again, social stressors will happen again. So it's about giving the life skills as well to people to know where to go, how to cope with themselves, what other options is there? Is there apps that you could maybe utilise if you're feeling anxious, if you're feeling distressed, if you're feeling pressurised in relation to finances? Where can we go to support you? So there is a lot of work being done. I think the first thing we're going to see is regionalisation of the liaison on our home treatment services. From the point of view of pathways, now we may not be able to regionalise the complete service delivery because we have 2 trust areas that are significantly underfunded compared to the other 3. So we would ideally want to bring those up to a level where we can provide a 24-hour service for liaison for home treatment. Looking at the Royal College standards, we look at home treatment, we look at peer support workers within that as well. So that's something we're going to look at going forward. So it's not just going to be purely statutory. We're looking to see how we can provide the right care to all of our citizens when they need it. So for definitive answers, when we're going to see things moving, we're working on it. There's a lot of areas working on together. Some are going to be moving faster than others, but we would hope to bring them all to fruition, that we have a regional crisis service that everybody has bought into, that has participated in the development of, and that will be happy with the delivery of.
Yeah, no, that's great. Thanks very much for that update. And I think even, take the example of the mental health liaison service. I think even if we were able to tell the public that, over the course of the next 2 or 3 years, even that alone, if we were able to have that regional service, that alone, that would be a big success around what a regional crisis service looks like. It would be something substantial that the public could understand and feel, because I just think up until now, it's maybe not, people on the ground won't really feel or understand what this regional crisis service means or what it's aiming to do. And I know all the good pilots that are already underway, but as you say, as different trusts are different sort of, have their own different circumstances. So I think even if if the goal or the aim was to get the mental health liaison service right across the board, that would be amazing. And obviously all the others, the MAP project and the community navigators as well. But so no, I wish you all the best for that work, and thanks very much for the updates today. I appreciate it.
Thank you.
Okay, that's Shin. So that's us. Thank you very much.
Okay, thank you.
That was very thorough, and just thank you for coming before us and giving the evidence, taking our questions. So, folks, Can I suggest that we maybe forward the briefing? I know of the mental health champion up in a few weeks, so I was going to suggest that we forward that briefing on to her just in advance of that, so she has that information. Everybody content with that? Okay, next thing I'm going to suggest is we take a wee 5-minute break before the next one, because I have to use the facilities myself. So we'll just go on to item number 6, oral briefing from the Department on Respite Services short breaks. Can I refer members to our papers at page 95 of the main pack, also page 2 of the table papers. Yeah.
Thank you.
So can I welcome Nigel Chambers, Head of Learning Disability and Autism, Mark McGuicken, Director of Disability and Older People, Oisin Martin, Co-Director of Older People and Children's Emotional Wellbeing, Lynn Preece, Director of Children's Services within the South Eastern Trust, and Colm McCafferty, Director of Children's Services within the Southern Trust. So you are all very welcome. And Nigel, we're just going to hand over, I presume, to yourself to give some brief opening remarks, and then we'll take questions.
I heard they were quick there. So good afternoon, Chair, and thank you for the opportunity to provide the committee with an update on services for children with disabilities and the additional investment announced by the Minister nearly a year ago. We are here to provide an overview of the changing operational context, the current position at a regional and trust level, and the progress made to utilise the additional investment to improve services across a continuum of need and care. The paper provided in advance of today's session contains a blend of qualitative and quantitative evidence to improve the understanding of the nature and scale of the challenges across services, whilst also setting out clear improvements that have been made in the past year and the contributions from families supported to stress the importance of the right support from the right person in the right place at the right time. Now, following our last discussion on this matter in March, the Department and Health and Social Care Trusts were very clear that further work was needed across the system to produce the urgent improvements that families were calling for. And in addition, we have established a more robust oversight and monitoring set of systems to better measure the additionality of as a result of the funding, while also retaining a close line of sight on existing bed capacity and utilisation. Now, there is a clear message to committee and families today. The clear message is that over the past year, a significant body of work has been progressed because of the investment, and we can now see the positive impacts across the region, across a continuum of services. Waiting lists for residential short breaks are down, and we can also see marginal but hard-won reductions in the number of children assessed as edge of care. These improvements can be attributed to a partly remobilised short break service, but also the significant volume of activity and service now provided upstream, meeting needs at an earlier stage and within the family home. In terms of culture and communication, work continues to shift the service from a child protection mindset to one that recognises that unmet need has escalated over a significant period of time, eroding the resilience of families and impacting the overall health and well-being of children with disabilities. Now, while today's message and update is a positive one, the view of the Department and Health and Social Care Trusts is that further work remains, and the progress made to date, specifically in short breaks, is fragile and will remain fragile until the residential needs of children with disabilities are adequately met. Now, in terms of context, work has been undertaken to develop a greater understanding of the population and presenting needs of children with disabilities, which will now be used to assist future planning of services and transformation of services. Of the 22,000 children in need known to social services, there are approximately 5,600 children known to Children's Disability Services. That is 25% of the entire population known to social services, and that represents a significant increase since 2016. And while it's accurate to say that we've seen sustained growth since that period, this growth has been exponential since 2020. which marks also the point that we can see a significant reduction in the short break service across the region. An area of rapid growth is autism, now accounting for half the children known to Children's Disability Services. And while this can be partly attributed to better awareness of autism and better diagnosis, we have to recognise and concede that more autistic children are slipping into the net of social work and social care. This seismic change in our population size and need has outpaced the capacity of services and our workforce. It is an important contextual point in understanding how our services, particularly short breaks, have been repurposed for residential purposes. Equally, it is important to understand that unmet need has escalated across a continuum of services, from family supports to early stage intervention and our ability to respond to a crisis and everything in between. Now, while the benefits of early age and early stage intervention are undeniable at this point, there will always be a small cohort of children with disabilities that will become very dysregulated in adolescence, and they will be best supported within a residential care model. To date, we have undertaken a regional needs assessment of the residential needs of children with disabilities, and it is concluded that Northern Ireland needs an additional 42 residential beds to meet need in the next number of years. Today, we have 26 commission beds. We need 68. This work forms part of a wider exercise as part of the strategic reform of children's services, and we are now at the stage of undertaking costings for ministerial consideration. Unless this clear gap in residential capacity is addressed, the short break service will always remain at risk of being repurposed to provide medium to long-term residential placements. I'll briefly cover the progress to date, but the paper sets out in detail an update from each trust, which we have largely provided you verbatim. But I would like to draw your attention to a few key highlights. As a result of the investment, we can see that an additional 377 overnight short breaks have been provided across the region, and capacity is due to continue expanding over the next number of weeks and months. Over 20,000 additional hours of supports have been provided for children outside of short breaks, and that also correlates with a comparable number of family support hours as well. In terms of, I suppose, getting to the inevitable so what question, what we can see now is the impact of this activity. There has been a 20% reduction in our waiting lists for overnight short breaks in Northern Ireland. In terms of Belfast Trust, Forest Lodge and Willow Lodge have opened for short breaks and residential placements respectively. This has provided a significant level of support for families, but there's also been expansion for families of services for those not accessing short breaks, including moving the Children's In-Reach Support Service from a 5-day provision to a 7-day provision. Northern Trust have completed their successful pilot of a transition of a meal with complex needs into supported living, which will now form learning for the rest of the region. That has been a key enabler to restoring partial short breaks provision within Whitehaven Respite Unit. This is due to move to full provision within the next number of weeks upon the transition of the second individual supported there. Now, while Lynn will be able to speak to the progress made within South Eastern Trust, Greenhill is operating now to support 13 children on the edge of care. Construction work is completed in Redwood, and we are now moving to RQI assessment and regulation. And this moves us closer to the next phase of work, which is the remobilisation of short breaks within Lindsay House. Southern Trust have expanded capacity in existing residential short breaks, utilised capacity within the voluntary community sector, and are now working to further develop their short breaks fostering model, which Colm can provide more detail on. I'm hopeful today that we can spend some of our time to discuss the benefits of fostering short breaks in providing an alternative option for some families in providing day breaks, overnights, and the longer-term potential to provide medium to long-term placements for children. And lastly, but not least, Western Trust have reported over 11,000 hours of short breaks and outreach activity provision, utilising capacity across a range of voluntary and community sector providers, including the NI Hospice. Now, by no means does this noteworthy progress take away from the challenges that are still faced by children with disabilities, their families and services. There are a number of continuous reminders of how much work lies ahead and the fragility of the short break service, particularly due to the gap within residential placements. Vacancy rates across children's disability teams have crept up, and in line with that, so have unallocated cases. And while this challenge is not unique to children's disability services, short breaks vacancies across the region can be found across multiple programmes of care, and the department is taking action. Both Lynn and Colm can speak to the work within their own trusts to address the unallocated cases and vacancy rates, but there's an important message to stress today, that the reduction of unallocated cases cannot be achieved by simply increasing the number of social workers. There is an important role for family support in terms of meeting needs for people who are currently awaiting assessment. Now, look, in conclusion, we are in agreement that there is significant challenges ahead in providing the required level of short breaks for our assessed population. I believe we should not take away from the substantial work that has been progressed within the last year, resulting in a vast expansion of early intervention and family supports, along with the additionality created within short breaks and residential care, ultimately resulting in the reduction of our waiting lists by 20%. So I'm hopeful that the evidence provided today provides the assurance to the committee and families that the Department and Health and Social Care Trusts know what the challenges are ahead, but we have a clear plan in terms of addressing those challenges and utilising the additional funding to achieve the maximum impact. So thank you.
Okay, thanks very much, Nigel. And there was some positive news in that. In terms of the additional funding that you kind of finished on there, it would be useful, without the minute detail, about just sort of where it was spent, because I mean, I note from your presentation you're saying that a number of the trusts are facing challenges with regard to recruitment. For example, it would be useful to know, what additional resources went in, how we plan to overcome the challenges in terms of workforce constraints, and what the department is doing to encourage more people into the workforce.
In terms of how the funding was distributed, we have provided this to the committee before. We can provide it to you again in writing. It was provided on the basis of capitation. Yeah. So by population size. It was the most efficient and probably fairest way to allocate the funding, with Northern Trust then receiving the highest level of funding reflective of its population.
I wasn't even meaning the trust, so I'm thinking, in terms of where that money went, percentage-wise, in terms of workforce, beds, other scenarios.
That can be, we provided that probably in our March update, but we can provide that again as an update. But yes, there'll be a certain amount of funding attached to what was provided in terms of residential short breaks, voluntary community sector, recruitment of staff. So that is information that we do have to hand. Some of how that money was spent up until March has had to shift in the past number of months, reflective of some of the workforce challenges. I suppose I'll pass to Lynn and Colm. Just how we've kind of navigated those. So I'm thinking probably around Redwood and some of the others.
Yeah, I'm happy to answer that. Thank you, Chair. So, yes, we did a significant recruitment campaign back in March for particularly Redwood. And since then, we have also done recruitment in relation to Greenhill and some of our Lindsay Outreach, which is an outreach support daytime short break service to families. So that was really successful, and we have managed to recruit to the majority of those posts. There's only a small number of those posts that haven't been filled. But crucially for us, we have been able to recruit also into our community teams, and we haven't utilised social workers to recruit into those community teams, because it's not always social workers that are needed to help support families. We've recruited some family support workers, and each of those family support workers will be carrying a caseload overseen by a social work service. So it's a social work led service. So that has helped us close the gap in terms of some of the vacancies that we have experienced. And certainly within the South Eastern Trust, we have experienced a drop in the number of our unallocated cases quite significantly because of that. We're just doing the final stages of the recruitment in the Lisburn area, and hopefully when that's concluded, we will see our unallocated cases, for example, reducing to a negligible position by December. So for us, it has been a successful outcome in terms of recruiting for the residential services, but also for the community teams.
Okay, thank you. So I'm looking here at, I'm saying page 111, it's a summary of all additional activity per trust. So there's 19,000 hours additional across the 5 trusts. I mean, some of the trusts have substantial amount of hours. I mean, the Southern Trust is nearly 10,000 additional hours, and other trusts have less than 2,000 hours. But when you divide that by the sum of additional families, so there's 1,786 families, it's kind of working out at 10 hours per family over a 6-month period, which my crude maths are saying like 1.5 hours per family. So I'm just wondering, is it as crude as I'm working it out, where it's equal, or is that some families maybe getting 10, 20 hours and some families getting none? I mean, because 1.5 hour per family doesn't seem like an awful lot of additional.
Maybe if I could help respond to some of that. I suppose it's important to point out this is additional, so it's not that it was starting from zero. Mm-hmm. So within all of the trusts at different stages, even prior to the very welcomed new investments, there was still a very significant activity taking place. So the additionality we're talking about is over and above what already had been there. So it's important to look at this through an already existing baseline of activity, and this was the additionality that we have been able to develop as a consequence of the new investments.
Let's just add to that as well. I suppose you partly answered it. Yes, there would not be an equitable distribution of support hours. It would be aligned to assessed need. So yes, you're right, some families would need more support than others, depending on where they're at in terms of the continuum of need. And also trusts, in terms of the decisions they had to make of how the funding was used, some would have been in the position to spend more of that money upstream than others, in that others would have had to focus more on the remobilisation of their short break service.
Okay.
Chair, I can maybe put a wee bit more meat on the bone of that as well, because I think the binary equation that you've engaged in there probably doesn't illustrate the differential allocation of resource to children. I've made some crude notes here myself, but investment in voluntary sector organisations in the Southern Trust, and this is an exemplar. This is happening across the region. Through the likes of the YMCA, 3 young people have received a total of 55 additional hours. Through Bernardo's Sixth Sense, 6 young people have received an additional 90 hours in total. Through the Brain Injury Trust, 5 young people have received an extra 20 hours. Play Therapy, 5 young people, 30 hours. Gold Line Support, 6 young people, 240 hours between that cohort of 6 young people. So the allocation of resource, it is differentially allocated based upon assessed need.
Okay, well that information has been useful then. So in terms of access to respite care, so you're saying, Nigel, there's 42 additional beds, we need 68 total beds in total.
Residential?
Yes. So based on the fact that we are short, what is the average residential stay then per person, given that we are short?
So that residential needs assessment relates to medium to long-term care. So that what, I suppose with the loss of the short break service, it's being squeezed through 2 different areas. One, there's a growing population where we've been unable to provide quite a diverse continuum of services to actually prevent or minimise their need for short breaks. You're talking hundreds, thousands of families are now accessing those services. That's what's coming from, I suppose, upstream. The other central challenge, and this is where the residential needs assessment is important, is that we have lost short breaks capacity to provide medium to long-term residential care for children that become looked after. So that needs assessment is around the medium to long-term needs. So you'd be talking a number of years for those children once they are moved into those placements. That would then recover the lost short break service. So with the money that has been provided to date, trusts have done targeted investments. So this is where probably the example of Whitehaven is quite useful, in that by providing transitions for 2 young people who are within Whitehaven into supported living with positive futures, an adult learning disability service, that enables the recovery of a commissioned 5 short breaks beds, which a number of families can use on a rotating basis, because it's a facility that has, I suppose, quite high volume. It can run 7 days a week. It can handle a higher level of complexity than some of the other sites. So that is the challenge we have. We need to work upstream for the population demand that we are seeing. We need to recover the beds that have been lost for residential purposes.
I mean, absolutely, the challenges are immense, and it's welcome that there's a reduction of 20% with regard to waiting lists. And I mean, but a lot of our conversations, because you know we've had you in front of us quite regularly, so a lot of our conversations have been quite rightly around the more complex needs. So in terms of you sitting in front of us today to give us an assessment of how successful we have been, when I say we, I mean you have been in terms of providing support to families, particularly for with children with the most complex needs.
Maybe if I could, it's important to look at this here through a continuum of care, and you know, I think the number of residential beds that has been muted at the moment is based on the presenting need in terms of how we're configured at the minute. Both from my point of view, in the sense, you know, we need to be much more ambitious and sophisticated, and we absolutely have to push and develop services more upstream. So in a way, from children's disability, we need to look at it from, you know, a basic initial family support, and certainly in the Southern Trust we're hugely indebted to a really vibrant community and voluntary sector, which we have been able to significantly upscale, particularly over the past 12 months with the new investments. And that, you know, getting it in early, as flexible as possible. Thereafter, it's about, again, a continuum. There is a significant cohort, and I would also suggest a significant potential for us to upscale short breaks fostering across the region, which provides really worthwhile overnight short breaks to children and families, for children that can be managed within that family type arrangement. If we get that right, it would reduce the demand for residential short breaks, and again, in the ideal scenario, which is what we need to be working towards, that children being placed in residential for short breaks are at a sufficient level of complexity that they can't really have their needs met within a family setting. And if we get that right, to have that regular, consistent response and support available through residential short breaks, the objective is that that would absolutely further reduce children on the edge of care and further reduce the need to have children in full-time residential. So that is the continuum that we need to aspire to in terms of seeking to get those processes in
and how
place.
close are we? I mean, I absolutely agree we need to aspire to it. I suppose my question is how good are we doing at this point in time?
So that is centrally why this funding has had to be spread across a continuum of services, because if we simply focused it on the short break service, whatever gains were made in terms of recovering the service would be simply lost by more and more children entering the system, increasing in complexity due to unmet need. And to take Colm's example, that is why by addressing a wider continuum of services with those with less complex needs, you essentially protect the short breaks and the residential service for those with much more complex needs. And in terms of my opening remarks, the panel we fully concede there is a very small cohort of children that will from adolescence become very dysregulated and will be destined for residential care. So to ensure the service is waiting for them, that diversity of support for the wider population protects that service for them.
Danny?
Thank you, Chair. Thank you very much for this update. I just want to go back to the start of this, and the start of it I think was last year, the Tara Mills documentary, I'm Not Okay, that highlighted this right across Northern Ireland, and I want to commend the families who opened their doors and highlighted the issues that living and caring for their children who were not having their needs met at home had resulted in very, very serious issues. And I don't believe there would be any progress without that documentary and without the bravery of those families being able to show us. So where we are today, the funding that had been announced by the Minister subsequent to that came from that. You know, the 2 million within the year and then the 13 million per year. And we've heard from Phil asking just, you know, where that was spent. We did get documents, I think, in March. And maybe if we could get an updated version of that, I think that would be good for us to see, particularly in terms of where it was spent on additional bed nights and additional short breaks. You know, that's what we want to see, where that money made a difference, you know, to families, how many more short breaks, how many more nights. And certainly I'm aware of what you were saying, Nigel, about the pressures within the short break system because it became residential effectively, and certainly in Whitehaven I'm very aware of what happened there. A 6-bedded unit became a 2-bedded unit for a long sustained period of time. I'm very glad to hear that that is now being resolved. I've been told it's been resolved again and again and again, and we have had missed deadlines for Whitehaven in particular, but I'm very glad to hear that one of those young people has now been into supported living, and the plans for the second one, so that that can be fully opened up again, and that the families in the area can start to get that service that they need in order to release the pressure on them. Can I just ask, with those families who are going back and getting their short breaks again, what is the time between their short breaks? You know, is there an average time when they are being able to access short breaks? And what is that? Who can take that one?
Do you want me to answer that?
Yes, please.
So it varies, and again, it's down to assess need. I mean, we are very clear that it's obvious a number of our families are in great need for a significant number of short breaks over a monthly period, for example. So there are families that are in receipt of maybe 2 or 3 nights per month, and there are families in receipt of overnight short breaks once per week, maybe twice per week, depending on the circumstances. So it depends really on the assessed need or the presenting need at any particular time. And I think what has been really important is the engagement with the families, just to kind of try and understand that and try and understand where they are at a particular point in time. So it really is back to the assessed need of a particular family at a particular time.
Those families, are they getting their assessed needs? Are they getting the assessed allotted time? Are they getting them?
There will always be a number of families that will not necessarily get the number of short break nights that they have been assessed for. So that is compensated for by other things. So for example, in the South Eastern Trust, and if I could talk about the South Eastern Trust in particular, we have increased the number of short break hours during the day to families, and I met with one particular family not represented today last week who said actually that was better for her. She felt that that was meeting her needs and meeting the needs of her son in a better way, and it's not that we are going to take away the short break night from that family, because they need that too, but it's just another way of offering a service to a family that they are benefiting from.
No problem. And I can see that, but from my experience, it's the short break nights that families, and certainly families in our area, that have been looking forward to be able to get again. Can you give us just a few figures? Just how many families are on waiting list? And I know you've said, Nigel, it's down 20%. Could you give us the figures for the waiting lists or for short stay facilities, and how long the average wait is?
Waiting list we have here is 263 families are on the waiting list for residential short breaks, which represents a reduction of 20% from 332 in April of this year.
So there's still 263 families. How many of those are designated as age of care?
That's something we probably have to take away. I mean, our age of care numbers are currently 81 across the region, so what you can take from that is not every family that is every family is waiting on the waiting list is defined as age of care.
So is there an agreed definition of age of care, that there is a standard definition of how do you define that family as being age of care?
Would look to our social work colleagues here.
Again, it's back to the presenting need. So it relies very much on the assessment and how the family are coping, and a range of other factors. So, for example, what family support they might have from within their own family, whether that is available, how useful that is or not, and what supports they have. So all of that contributes to an overall assessment of how a particular family might need a service.
I can maybe make a remark on that front as well.
There is a standard criteria for falling under that definition of age of care?
Well, we do a Unit-Gini assessment, so a number of things fall into that in terms of how do we assess a child in need. Now, a child with a disability is a child in need, so how we assess their needs beyond that in terms of what it is they need for, whether it's an overnight short break or whether it's a daytime short break or whether it's external other supports, all of that falls into the assessment. But in terms of the criteria, it depends very much on what a family's coping mechanisms are, what other support strategies they have, and what other family networks that might be available to them.
Yeah, so the mobilisation of the in-year monies has coincided with the introduction of monthly oversight meetings, and that in turn has necessitated from within SPPG an interest in those edge of care figures, and they are now collated centrally by SPPG within the context of that monitoring activity. But I suppose taking a briefing from the people close to the ground in relation to that prior to today's committee meeting, that is now starting to yield a dividend in terms of being able to embark upon a much more granular assessment across the trust areas of where the unmet need really is. So for instance, in the Northern Trust area, a view is starting to emerge that it's the northern part of the Northern Trust area, the Coleraine locality, that in the future is going to need core investment. In the Western Trust, it's the southern part of the Western Trust. Belfast Trust has a more generalised need for investment across the piece, but that data is being collated now. I think it's being collated in response to a concern expressed at this committee that there wasn't a data set informing activity in and around that, and hopefully we can appropriate that to commissioning activity in the future. But to double down on what has been said, you know, there is going to be a need for long-term sustained investment moving forward into the future. Absolutely.
Certainly what we have at the minute is nowhere near what is going to be needed. We know that.
No, and I think that point has been made by other people appearing in front of this committee previously. But that doesn't mean that we're not ambitious and determined. And there has been an incredible amount of work that has taken place in this space. But I wouldn't want to infer any complacency about that. The benefits that we've seen have been hard won. The system is still incredibly brittle. And I think it needs to be recognised, and I'm sure it is, that the young people that we're talking about are extremely complex young people in their own right. And these sort of binary equations where we look at the number of beds available and the number of nights that translates into, sometimes we're looking at ratios of caregiving that mean we can't use all the beds. In maybe a 6-bedded unit, we can only use maybe 3 or 2 at any given time. The challenges in the Western Trust in the Rosebud unit, they really endorse that, where we have one young person in a long-term placement whose needs are so complex that we couldn't approach placing any other young person there for a short break while that other young person is there. So I think the data needs to be interrogated with that sensibility in mind.
No, I appreciate that, and certainly, you know, I'm aware of cases where young people require multiple members of staff, and sometimes up to 4-to-1 ratios. You know, where somebody has been living at home with their family, but when moved into a service, they require high numbers of staff in order to meet their needs. So there is a.
And within that context, some of the novel ideas that have been shared amongst the trusts and moved forward in the last year in and around InReach. In one trust it's called InReach, in another it's called Outreach, but it has provided models of short break provision that maybe don't always extend to overnight provision, but they are nonetheless very meaningful. And they generate space for families to have family time in a different way, or free parents up to spend time with other siblings. And I think, you know, from a utilitarian perspective, we're obliged to think across the broad spectrum and continuum of services and think in that space about, you know, novel ways and different ways of providing short breaks.
I think even on that as well, Dan, if I could add, even in terms of how RQA have worked with us, they sit on the oversight board as well, and they've worked with us in a very collaborative way. Now, they still have the regulatory role to take, but in terms of the 2 young men in Northern Trust moving to supported living at 17, rather than having to move somewhere else and then move again at 18, they were very supportive of us in that approach. So we're, across the piece, we're working to make sure that what we can do is done to deliver the reopening of the short breaks.
And I know people will be very glad to hear that. Can I ask, just in relation to what you were saying about the families, what are you also doing to support the family members? Is there any other services available to the other siblings, for example, and other members of the family?
Yes, so for example, where there are other children in a family home, we would absolutely provide support, and that could be in after school activities, after school care, additional direct payments to families, or self-directed support that they can utilise in whatever way would be most helpful or meaningful to them. So when we kind of do an assessment, we take account of all of the family members, including other siblings.
Okay. Similar process, yeah.
Okay, no problem. Okay, thank you.
Linda?
I'm going to pick up on the very last point first around the direct payments. They can't be used whatever way the family wants. That's the reality for families, particularly those with children with medical needs. So you may have a child who is assessed as needing 8 nursing hours and 6 social hours, and they're given their 8 nursing hours and told we have no provision for the 6 social hours, and you can't use direct payments because your child has a nursing need, a medical need. So this one's probably directed at our departmental friends here. What is the Minister doing to address that? Because it needs to be addressed. It needs to be addressed urgently, because at this minute in time, this is a real bone of contention within trusts for families. I'm quite sure for you and your job as well, trying to look at what is available, because essentially direct payments are not available to those families who have the most complex medical needs. So
there's work ongoing, there's a number of streams ongoing, Linda, on that. There's work ongoing around what can and what cannot be delegated. That is work which is ongoing, led by the Chief Nursing Officer and the Chief Social Work Officer within the department. I sit on that from a policy perspective as well. So we've been talking around this issue around what can and what can't be delegated for some time now. We're taking further legal advice around what can be delegated, whether a social care task can be delegated or whether it has been a nursing task delegated. We're also doing a piece of work through the Collaborative Forum, looking at how we make better use of managed budgets and how we support people who are getting direct payments in a better way. So there's a project being taken forward through Impact, which will look at running a number of pilots across all trusts, to look at how we better utilise direct payments and the whole managed budget sort of suite of work. I agree, it's really challenging, and it's really challenging equally when you're caring for someone and then taking on the responsibility of employing somebody through a direct payment if you're employing a personal assistant. So we are very aware of that. I agree with you, it's challenging. I agree with you, there should be consistency across all trusts, and it should be easier, and we should look at actually what it can be used to deliver. So we're looking at a number of projects which have happened across the water around sort of prepaid cards and things, which will make a lot of those processes easier in terms of what you have to give to the trusts around the receipts and the governance around that. We are looking directly at what they can be used for as well, whether family members can, we've relaxed the rules again around family members becoming personal assistants and being paid for some of that support as well. So it is a huge issue. It's just another issue we're dealing with at the minute. I don't have a time scale for you when it'll be resolved. I don't have a programme to say here's exactly what we're doing, but it has been taken forward under the auspices of the Social Care Collaborative Forum. It's one of the work streams within that in terms of the wider social care reform.
When we do have a time frame, can we get it? And it's a source of frustration to families that they're getting letters sent out to them to say you can avail of direct payments, having been told they can't avail of direct payments. Absolutely. Being told you have 6 hours of social care needs, but nobody who is not a nurse can provide those needs, but we're giving you 8 hours of nursing needs, but we're not giving you the 6 hours of nursing needs, even though your child has nursing needs. So I'm just making the point again because I think it's worth making. Those are children with very significant medical needs. So
just to add to that, we're very aware this is an issue that transcends children's disability services. It's just a big issue within adult learning disability services. The department's fully cognizant that people with learning disabilities will be born with a much higher level of comorbidities than the general population. We need to get these medical issues and medical supports right, because in our previous discussion we talked about transitions of complex people. If you don't get the medical bit right, you limit their transition options when school finishes, because their transitions options get defined by their peg feeding, by their epilepsy, by their diabetes, as opposed to what they want to do. and how they want to do it and who they want to do it with. So
No, I agree, and it's a much wider issue, obviously, just in terms of people with disabilities dying much younger, and we've seen all of that evidence on the programme that was done in England. So, I mean, that is something that absolutely needs to be addressed. But I would like to see something coming from the department in relation to that direct payments issue.
Provide some to the committee.
No, I appreciate that. And I'm aware of the work that Impact are doing, and actually I've been able to use them very recently to help a family, so that hopefully will be of some help to some families, but obviously it will not address all of the issues. Just the figures that we have here in terms of the children known to children with a disability known to social services, children on the edge of care, waiting on residential short breaks, have all reduced slightly, and it's not in significant numbers, but there's a rise in the number of unallocated cases. Are the unallocated cases assessed in those top three? So are they, whilst they're unallocated, well, I'm assuming they're known to they're a child with a disability known to social services, or they shouldn't be in this table at all. So sorry, this is in your paper on page, it's 100 in our papers, I don't know.
We have it.
It's the current position. It's the page with the current position, Nigel.
Look at the
So the unallocated cases, then, do we know that's reduced by 2? But do we know among the unallocated cases, are any of those children on the edge of care? And do we know among the unallocated cases? So just because I'm trying to simplify this, I think I'm making this more complicated than it needs to be. Whilst they're unallocated, have they been assessed? Was it probably the easier way to ask that?
Sorry. The children who are assessed as being on the edge of care and the children who are on the waiting list for residential short breaks have received an assessment. The children who are unallocated aren't part of those two groups. So those children would be the more complex children, and those would be the children who would be assigned to a social worker and would have a social worker working with them. The number of children that are unallocated, that would tend to be, in my experience, the group of children who would have much lower level needs, who can be worked with by a family support worker, for example, and they would all have an assessment. So they would all have an assessment to determine whether or not they can be managed with a family support worker or whether they need a social worker.
Okay. The issue around assessment whenever there's a reduction of respite or short break, that issue of when somebody who needs residential care goes into a setting and therefore that setting can no longer be used for that short break service. My experience is service has been reduced to everybody across the board. So are each family actually being assessed? Because we do know that some families may be in greater need for lots of different reasons. They may have other caring responsibilities. They may have somebody who is bereaved. They may be in mental distress themselves. There are a number of different reasons that they may be in greater need. So is that assessed, or is it just done as we have to reduce everybody? We can only give so many nights now, so many hours, so we're just going to have to reduce everybody across the board. Can I be given reassurance? And is this across trusts, or is this something that is left to trusts?
This is ultimately about prioritisation of service when your need exceeds supply. Our trust colleagues, so people are proud, these are difficult decisions that trusts have to take.
Yeah, so I understand that, but is there an assessment done of each family whenever they have to reduce that, or is it done as we have to reduce everybody, it's the first way to do it?
It wouldn't be, in my experience, that it would be a broad brush approach. It would be my experience that we would prioritise the greatest need. That would be the experience in my trust.
Is that a direction that comes from the department, or is that left to trusts?
It's an operational decision for the trust. We haven't directed trusts that would be the approach.
They may do it.
They may do.
I'd maybe offer a comment or two about the real politic of what unallocated cases are, because I think the question, forgive me, that you're posing is, are these children who are lying fallow with no attention being spent on them? They will all have received an assessment through the initial reception gateway process into the trust. Young people can become unallocated for a range of different reasons: social work vacancies, maternity leaves, illness. The teams do continue to provide an oversight and monitoring role in relation to those unallocated cases, and as Lynn has said, high risk, high priority cases would not be allowed to gravitate down into becoming unallocated cases. I think there's also a part of this discussion that needs to reflect upon unallocated cases being a perennial challenge across all children's services teams, in particular the family support and intervention teams. But there's also a part of the discussion in relation to this cohort of children that needs to advert to the reality that they don't all require an allocated social worker to achieve traction in terms of services being provided. There are other professional grades that can provide care at band 3, band 4, band 5 within a social work-led model. In relation to the broader questions posed, it's maybe something that we need to go away and engage with the trusts about to provide a bit of narrative to offer the assurance that you're looking for.
I appreciate that, Oisin, thank you.
I just come in just to give an example in terms of the unallocated cases in my own trust. We did an exercise of those young people by using Encompass, and what Encompass told us was the number of visits and professional points that those children had been seen, and in fact in one case we were reassured that one child had been seen 91 times by varying degrees of professionals at different stages. So in some ways that provided us with the assurance that those children are being seen and their needs are being met, whatever that might be. So being unallocated for a social worker is not going to reduce the services that the families and the children actually need at particular points, from AHPs, for example, schools, whatever it might be.
I appreciate that. In terms of the additional residential beds, Nigel, that you've outlined, the additional 42, so that's across the region, that's across the north. And are you looking at that in terms of the provision of those additional beds? Is that been looked at as some for this trust, some for that trust, or has that been looked at on a regional basis? You know, we're going to provide these beds. I'm going to say the same to you as I said to the last people. I'm not asking this to catch you out. You know, are you going to provide those beds right beside where everybody lives? Because I know that's probably not going to be possible, but I just want to understand, is it going to be, my actual reason for it is the regional equitable, today. I want everybody to get equitable access. I don't want people to be sitting in the South Eastern Trust not able to get a residential bed, and everybody in the Southern Trust, which is my trust, and I could be selfish and say I want everybody there looked after, but I want to make sure that every single family who needs that support, every single young person, child that needs that support is getting it. And then, so just I suppose as an aside to that, Colm talked about, you know, we may not need that level if we did the upstream stuff. So if people were getting the short breaks, so are we looking at that's something we need to plan for, but let's invest in the short breaks and see, can we reduce that?
There's a couple of questions there.
And are the committees in common talking about this issue as a region-wide issue, and how they help each other, and how all trusts ensure that everybody is looked after in the same way?
So the needs assessment was undertaken in collaboration with all 5 trusts to understand what they need within each trust area, so that's how you get the figure of 42 needed. In terms of the next phase of that work, we need to undertake a costings exercise, both the revenue and the capital lens. We've been working with trusts to try and understand what existing estates are there that could potentially be repurposed, because that is it's a significant increase in the residential service, as I said in the opening remarks. We currently have a commissioned 26 beds. That excludes the lost short break piece, but we have 26 beds in Northern Ireland. We need an additional 42. They will be provided on a local basis, as trusts will provide services, local services, to meet the local needs of their population. You know, there was a question there about equitable access, and generally with short breaks, what we find is that, with the exception of Belfast and South East, trusts will provide short breaks to their own population. But if we addressed it at residential demand through sustained investment, which would take years in terms of capital and workforce, you wouldn't need to be in a position where one trust would need to access the supports of another, because we'll be adequately providing services against the assessed needs of the population.
and again, you know, if the committee would find it helpful, I think it's really important that we don't just solely focus on residential short breaks for the reasons I talked about, basically, because even if we were to go down the track of commissioning those 42 additional beds, it is hugely expensive part of the service. So what we need to be clear about is that we are looking at all other alternatives: early intervention, prevention, community and voluntary. I talked about short breaks, fostering and so forth earlier on. And it's really important to maximise that in all trust localities, because I believe that is actually when you get a really accurate picture of what the need is for residential. And it's really important that we focus on that.
And just to add to that, question about the committees in common. So can you just maybe, Colin, is that being discussed at the committees in common about what works best in each trust and how that can be then rolled out to make sure
it's committees in common have just had their second meeting, and I think it's fair to say at this moment in time it is very much medical orientated with a number of priorities around there. So to answer your question, and this is not, but where it is being addressed at the moment is through the various work streams that were established following the independent review, otherwise known as the Ray Jones review, where there were a number of work streams established. For example, I chair the fostering work stream, of which a component of that is the preferred model of short breaks fostering for children with disability. My colleague in Belfast chairs the residential work stream, which looks at all of that basically. So as we potentially move towards regionalisation of services, all of those work streams will absolutely need to focus at consistency of provision across the region.
I mean, that is what I want to see. I want to see every family that needs support, because I am really worried about the false economy and what we're costing our health service, and I understand why the committees in common are focused on the medical stuff right now, but actually that's been the problem. That's why our children and adults with learning disability and complex needs have been neglected for so long, because they are at the bottom of the pile. It's a bit like the previous presentation, you know, those with mental health needs and addiction services. And I don't even like using that term because it's not fair, and it's a bit cruel, to be honest with you, to say it, because you're talking about human beings and families. But it is the truth, you know, and they've been neglected, and that costs our health service, and it costs us all. These are children who want to have good, fulfilled lives, and families who end up breaking apart and with their own physical and mental health needs. So it costs our health service. This all costs us.
So I think, Linda, to pick up on that and pick up on Danny's point as well, the Minister, on the back of meeting the families from who are sitting behind us, he did put that investment in, and he did prioritise the investment, and he's made it recurrent. But that is only the first step, and we appreciate that. There's a lot more needs done on it. But I agree, probably a lot of the social care elements of health haven't got the true focus they might have done. I firmly believe under the previous minister and under this current minister, social care is now spoken in the same voice as healthcare. I take your point about the committee in common looking particularly at the acute element at the minute, but I suppose I could say it's on the agenda, and we're getting it on the agenda in terms of social care, the children's and the adults. It is now getting the recognition it needs within the department.
Okay. And I'll wait for you to come back on the direct payment stuff.
Right, yeah, we'll come back.
That's a big
I think we've committed to writing back to you as well on the managed budget pilot a few weeks ago. So that's coming to us.
We'll put it in the same paper. Yeah, that's
Thank you.
Maybe we get an extension on that paper then.
So, Mark, you just you mentioned there the investment. Are we on course to spend the 13 million this year?
We're on course. We're working with every trust. Part of the role of the oversight board is to scrutinise the delivery of that. There are challenges with that, Chair. In terms of the 13 million, we have a bit of an underspend at present, which we're working with the trusts to deliver in terms of that underspend. It's really challenging in terms of workforce. We've said that already. Some of the trusts are doing, particularly Southeastern, are doing a different approach now to recruitment. We're still doing recruitment in a scenario where largely there's an embargo on recruitment, so we're still prioritising some of these areas. We're working with each trust to make sure they're fully utilising their money. The position of the department at the minute is normally that if there's an underspend in any other area, it's brought just back into the centre to try and meet the deficit. Minister has been really clear with us that he wants this 13 million spent for the purpose it's been spent on. So at this point, we're not handing anything back to the centre as part of that deficit. This is being spent, and we're doing everything we can to make sure it's spent on the purpose the Minister allocated it to. So we're working with every trust on a monthly basis, Chair, to make sure that money is spent. There are some underspends, and we're working with the trust at the minute to try and utilise that. And if it's an underspend in one trust, we're not saying, I know Nigel mentioned at the start, we did it on a per capita basis, but if there's an underspend in one trust and they genuinely cannot spend it, we're making sure that's offered to the other trusts. And we're looking imaginatively to say whether we can do something in terms of moving some of this from programme to capital in year to do something which could be done in year. Basically, the Minister's told us to do everything we can to make sure to spend, and that's what we're doing. And so that's part of the role of the Oversight Board, which meets every month, to scrutinise the plans and to see exactly what has been delivered as part of that investment.
And also to intervene where we can see an issue where the departmental intervention, a discussion with a trust, the RQIA, can remove any blockages in terms of delivery.
Oh, thanks, Chair. Oisin, you had a comment there that pricked my attention, and that was about the data that is informing need, and you specifically referred to the north of the Northern Trust, an area in which I would represent, the North Coast area. How will you referred to the investment that will be required there in the future? How will that look? I know the simple solution that some people might ask is let's build more, but I think Nigel and Colm has already clarified that it is a very expensive thing to do, to build additional residential and respite units.
It is.
And for those people, for those families who will be keen to see what that investment will look, could you provide us some detail?
I suppose we're at a very early stage in our relationship with that data. And in part my answer would pivot back upon the remarks that have already been made by Mark and Nigel in relation to the longer term investment of money in capital projects as much as anything. What we're starting to see is how the data can be appropriated to illustrate where the hotspots are. And the northern part of the Northern Trust area is one sector that is quickly emerging into view amongst three others in the region, Belfast Trust and the southern part of the Western Trust also, where part of the problem for families is the amount of time that they have to invest in travelling to and from where the resources are. And you'll appreciate in your constituency there's areas of considerable rurality. But we also know in some rural areas, particularly in the Western Trust, there's big challenges with recruiting to some of the core professional multidisciplinary posts that support the provision of services, psychiatry and psychology in particular. So we're at an early stage in our relationship with that data. And I don't know that I could answer any more substantively at this stage.
Just around the summer grant schemes, which the Northern Trust highlight has been very successful, could you tell us a bit more about how that benefited families?
You can. Just give me a second, please.
Maybe as well, could you maybe tell us, and I'm not in any way begrudging any families, and this is an absolute need, but how much was spent on that? I note there was 287 families that benefited from that.
In terms of the breakdown of spend, we will provide that to you outside of this meeting. When we provided it before, I'm conscious that our previous written updates for the March meeting, as well as our updates over the summer, we've drowned you a lot in information and data to the point where even as officials it's difficult for us to see the patterns, and we were keen that for this submission to try and provide a high level of information so that you could see the additionality and that you could see the actual impact across some of those regional numbers. But within that then we've maybe lost some of the information that you do want to see at a granular level in terms of what the spend is and actually what that, in terms of the summer grant scheme, what that actually is in terms of what is it providing, what are the things that are at funding, so we can provide that for you. I suppose what I would say generally about summer activities, like the department, trusts around the table, trusts generally, are conscious that summer holidays, any holidays when the break, when special schools stand down, are a real crisis point, a tension point for families, something that they worry about instead of look forward to. And across our trusts, I'm looking to Colm, probably in terms of the work that you're doing in summer provision, a number of trusts have expanded their summer provision, their Easter provision and Christmas to try and help, I suppose, meet that gap. So summer grants were part of that. That was a mechanism of doing it. Colm's Trust, they did something different, but they've all went about summer in a different way.
Are these summer grants new, and will they be rolled out every year from the 13 million recurrent?
If I could, certainly in the Southern Trust, that's absolutely what we're doing with regards to it. We've always had a degree of able to upscale activity. Again, as I said, really indebted to our voluntary community sector who work closely with us in respect of that. But the new investments has enabled us to commission extra activity with regards to that. The other thing that I would have to mention as well, we also have a very good working relationship with local council, and there's a number of very, very good summer schemes, and indeed around Easter time and so forth, that we do in collaboration, particularly with ABC Council in Newry and Mourne as well, basically, and it's a joint venture, and certainly the additional funding enables us to mainstream that and have it on a recurrent basis.
And from the 287 families that benefited from that scheme in the Northern Trust and those thereafter, which I seen has been rolled out to most, if not all, trusts, was there feedback collated on the back of that?
I can answer, and I bought a wee bit of time there to scrabble around for the specific information. There was £70,000 mobilised in the Northern Trust area in collaboration with the May Murray Foundation.
And the other trusts, what do you know? Do you know in total what was spent?
I don't have the total.
No, that's okay.
Immediately to hand. However, in relation to that second question about feedback, there is positive feedback on offer from those families engaged. As a telling additional aside, there's very positive feedback on offer from the staff who are involved as well, who are expressing a sense of renewed morale and belief in what they're doing, because they're able to mobilise that money and engage with families in novel ways that maybe hitherto hadn't been the case. It's no substitute for the core need for residential overnight short breaks, but it is making a difference, and there's testimony on offer from a number of the trusts in relation to that positive feedback.
I would add a couple of points. So in terms of the data sets that we've built since we last spoke to you, they're developing further, and I can hear from the questions today there's an appetite for more granular data, but we don't want to drown you in that level of data that actually inhibits being able to actually tell a story, whether it's positive or negative. What I would say in your trust area in terms of where the bulk of the spending has been, it has been for the recovery of Whitehaven. I mean, those two transition arrangements are essentially high cost placements. I think from memory they average at 700k per placement, which would be comparable to what we would see in high cost placements in adult learning disability. So that will be what their recurrent spend is.
And I suppose, different trusts for different reasons are in very different places with it. And again, because we have very good support from our foster carers, and indeed we had been able to maintain our short breaks residential. The majority of our investments has gone into the voluntary community sector, with some enhancements in terms of new service developments and social work teams as well.
We received some commentary about some of the positive action within the South Eastern Trust, and that was focused on around engagement with families. Have other trusts taken very similar proactive steps in terms of engaging with families?
Again, if I could say, we would be very indebted to quite a number of families who work with us, and maybe the committee would be familiar. Going back a number of years, there was a paper that was regionally endorsed and actually launched in this very building called Our Journey Through Disability, which subsequently became known as Our Journey, which is absolutely based on wholesale family engagement, by and large written through the lens of the family in terms of their experiences, hence Our Journey Through Disability. So every trust very, very much focuses on seeking, there's never a perfect system of service user engagement, but it is something we absolutely are committed to, seeking to continuously try and improve that.
I can maybe provide a bit of additional perspective on that as well, Alan. There has been a robust piece of PPI engagement with service users within the context of the expansion of the InReach service from the Belfast Trust, which has garnered very positive feedback, but was also central to the redesign of that service into a 7-day per week model. Families were saying, look, we need support at weekends, at times when the children are not at school. There's also a regional consultation with children and young people that's being embarked upon through the Cedar Foundation. They're actually meeting this evening, I think, down in the Southern Trust area, where we're actively engaging with children and young people, and on a de facto basis their families in relation to the overall design of services. So we are moving forward with that sort of collaborative intent.
Issues of time, Chair.
Okay, folks, no other members have indicated, so I just want to say thanks again for coming before us and answering our questions. We appreciate it. It's not easy, Nigel, submitting us with the correct information. I think that the report that we got was very, very useful. I mean, there is some additional information that would be helpful, so if we can get it, that'd be much appreciated. So thank you.
Thank you, everybody.
Okay, folks, so is there any we have in the course of those questions asked for some additional information? Is there anything any members want to add to that? No, content. So moving on. Sorry, Linda.
Just the things I have asked for, but that's already noted.
Yep. So item number 7 was supposed to be a written briefing from the department on the maternity review report, but we haven't got it, so we're hoping to have it by next week. So item number 8, adult.
Sorry, Chair, just with that, could I ask, how long have the trust, or how long had the department known that this deadline was coming, that this was due?
Quite a long time.
It's been scheduled into the forward work programme for a while. I know there's work being done on it, but I don't think we've been able to get it to us in time. And they've requested that it be rescheduled to next week.
Months.
Definitely overdue.
Yeah.
Boom, boom.
So it's disappointing, but I mean, we don't have it, so we can't talk about it. Item number 8, Adult Protection Bill, call for evidence. The response list. So can I refer members to that list at tab 8, it's page 126 of main pack. Just to let you know, the clerk will prepare a draft schedule of briefings for agreement at next week's committee meeting based on that. So do members have any comments? No? Okay. Correspondence, item number 9. So can I just refer everybody to the correspondence tab, page 130 of main pack. Are people content with the actions as designed? So can I just, at item number 13, there, just if I bring it up, 2 seconds. The protective mothers, safeguarding breach. So I was just going to suggest that we don't note it, but we actually forward to the department for comment. If people are content with that.
Yep.
Okay. Anybody, any other issues? None?
I know it's in the, sorry Chair, just as the action for the minimum unit pricing one. So we're going to schedule a briefing with the Department of Health. Do we know roughly when?
We didn't on that yet, so we haven't.
Of the department, David?
Yes, we were just waiting on. It'll be scheduled at some point in the, hopefully before Christmas. But
thank
you. Okay. So I'm going to go to any other business and then date time place meeting. I'm going to go to forward work programme and close session. So any other business? No.
Sure. Just a couple of meetings ago, we had a presentation about Encompass, and I had sort of said that I'd had difficulty getting on to my care, and that night I went in to check if, in fact, I was on it, and yes, I was on it. And the difficulty I had was getting my wife on to it. She wasn't on it, but I was on it. And I checked, and I had 4 pieces of correspondence on it. 2 of them were from the City Hospital in relation to cardiac appointments and reviews.
Just be careful, all the information you give here is broadcast live.
Okay, so I had received those, the information in that in hard copy. But there's 2 other correspondence from the Southeastern Trust relating to an appointment that I had, and I've always been complaining about people who don't turn up for appointments, but apparently there was an appointment and I hadn't turned up for it, and then a subsequent piece of correspondence from them to tell that I was then taken off a waiting list. And now I got profuse apologies about it, but I'm just wondering, what's the process? Are the public expected to monitor my care almost on a daily basis to check if there's any appointments coming in for them, or is there a backup? Do you get text messages, or do you get a phone call, or what way does it work? But I just thought it was disappointing, and I thought that if that had happened to me, I wonder just maybe how many other people. And we hear about so many people not turning up for appointments, and I'm just wondering, could that be a contributory factor?
Yeah. It's something I think we should look into. I know in my scenario, I have set notifications, so if there's something goes into my care app, I actually get notified about it. I'm not sure if it's an email or whatever, but I get I get an alert that when something goes in, so it may be a case of setting, but I'm pretty confident that, and again, just on my own personal experience, I think I always get a written, if it's an appointment, I've got
something. Yes, some notification.
Something
I didn't get
fridge.
any notification.
Yeah. So, but I do think it's a very important point that we should clarify, because you could be right. There could be lots of people who have my care set up, and
it's a shame because it's a wonderful system.
Absolutely
wonderful system. No criticism of it.
Because I actually had an appointment last week where I was able to do the pre-appointment work on my care. So I'm very impressed with it, to be honest with you. But that's not to say that there aren't issues. So I think if we correspond with the department just in relation to those points raised. Thank you, Al. Any other issues? None. Okay. Next meeting. Next formal committee meeting is next Thursday, 16th of October at the Nikon Conference, Le Mans Hotel 230, which we're going to talk about now. So we're going to get